Good afternoon, everyone. Welcome to the very first meeting of the Interim Healthcare Committee. We're glad to have all of you here, and the first order of business is to take the roll call. Jennifer?
Thank you. Representatives Kaiser?
Here.
Anderson?
Here.
Dobrovich? Here. Begley?
Here.
Casper?
Here.
LaFour?
Here.
Meyer?
Here.
Nelson? Paulson?
Here.
Weiss?
Here.
Senators Morris? Dever?
Here.
Hogan?
Here.
Lee?
Here.
Mather?
Aye.
Elke? And Beta.
Here.
Mr. Chairman, we do have a quorum.
Thank you, Jennifer. The next item on our agenda is a review of the supplementary rules of operation and procedure of the North Dakota Legislative Management Committee. Jennifer?
Marvin's here.
Yeah, we got it.
Thank you, Mr. Chairman. Committee members, in your packet, your top item should be this vanilla colored document. For those of you who have been around before, you've seen this. Not much has changed. There are a couple things I want to bring to your attention. Just going into our interim. One of them is attending remotely. Reminder that in order for this committee to offer remote attendance, it needs to be approved by the chairman of legislative management, and then it needs to be offered to every member of the committee so everybody has that opportunity. Every member who is present must vote for or against whatever measure we have, whatever question we have before us. One of the things that I'm required to do is to request that presenters provide us the electronic copy of our documents. We do that. I do that. That means that if I've been successful, you will be able to access those documents on the agenda. Those links stay live on the agenda until the minutes come up, at which time those links are moved to the minutes. So you can follow along all our attachments that we've gotten. Members of legislative management are welcome and encouraged to attend our meetings. At permission of the chairman, they can sit up at the table with us, and we'll give vouchers for them as well. As it relates to the jurisdiction of this committee, we need to be careful not to have any substantial expansion of the committee charges that we've been given. Remember, we've got our two reading rule. If this committee is going to consider a bill draft, if that bill draft is not drafted by legislative council, it needs to be presented in two readings. Technically, if it is drafted by legislative council, it does not need the two reading rule. The rationale there is that it was requested at one meeting to give notice and then presented at a subsequent meeting. All communications and expressing policy of our interim committee need to be referred to the chairman of the legislative management for approval prior to introduction during the legislative session, prior to publication, or prior to distribution. And then if we were to have a consultant, we would need to run that by the legislative management again. The legislative management chairman can expand our duties if there's something we come across that we want to address. And then finally, and importantly, remember we don't have any subcommittees unless they are approved by the chairman of the legislative management. Are there any questions on our background rules?
Thank you very much, Jennifer. Committee members, in terms of remote attendance, it takes almost an act of God to get that approval, and that would be the leadership of the legislative management. We have done it in this committee in the past for a member who was really critically ill and absolutely could not make the trip. They were allowed to do that, but short of that, it's only appropriate for all of the people that attend this meeting, the members of our audience and the public, that we be present for the meeting so we can have dialogue and meet their needs. The next item on the agenda is comments by the chairman. This is going to be a little bit longer today perhaps than normally, at least for me. First of all, I want to take a point of personal privilege and introduce Caprice Knapp. Caprice, if you'd stand up or wave. She's our new Medicaid director, replacing Maggie Anderson, and we're very happy to have her here. If you have any questions about Medicaid, please ask Senator Lee, Representative Weiss, or Caprice. Thank you, Caprice. Last week I was listening to a show on the radio as I was driving around, and they got talking about affordability and accessibility of healthcare. And it was interesting to me that the thrust of the discussion was, what do those terms mean? Have you ever really thought about it? As policymakers, as politicians, I know I've used it more times than I can count, probably, talking about those two items. But what does it really mean? Is it affordable? Is it accessible? And so this committee, this time, we have 4 broad study areas. We're going to be covering those today. This meeting is short simply because it's a procedural meeting that we'll be using to set up the rest of the interim with, by going over the studies and having some input today relative to these studies, but very minimal. For members of the audience, this committee always has had a pre-meeting planning session. We did not have that this time simply because basically it's a procedural meeting, and as a result, we didn't think we needed to do that. However, from this point forward, we will be inviting any interested parties in the audience who wish to attend that planning meeting to let Jennifer know, and she'll put you on the list, and we'll get a hold of you prior to the meeting and let you know when they occur, and you're welcome to participate in that. I was speaking to one of the members of the committee, and of all the issues confronting our state, health and related issues to health have to be number one. There are a lot of important issues facing our state, but I look back, and I'm not going to spend a great deal of time talking about it, but we did pass the reinsurance legislation for the individual market last session. I had the privilege and honor of carrying that bill before the Appropriations Committee. And if you think that was a fun thing to do, you're mistaken. It had a price tag on it of $32 million. And it had a projection based on the work of the consultant of over the next 10 years being approximately $800 million. And I have to tell you, I have no confidence in the $800 million. I will predict, and I will take a bet that it would be over $1 billion if we were to continue. So we have important decisions to make. Do you want to continue to keep the state in the reinsurance market and to provide reinsurance to the individual market to stabilize it at a price tag of possibly $1 billion over the next 10 years? That's going to be a tough step, both from a policy standpoint, where the state is getting into the reinsurance business for healthcare, and in terms of the cost associated with it. The underinsured people of our state, we use that term frequently, they're growing. The underinsured folks, your constituents and mine, are growing. The high deductible plans are growing. That has a lot of implications for providing accessibility and affordability of insurance. We have a number of uninsured folks that still will need health care at some point. Talking with someone just this past week who took their child to the emergency room for a true emergent issue, sat there and watched people walk in the door with relatively simple concerns, legitimate health concerns, that should have gone to a walk-in clinic but chose the emergency room. And so we've got issues that we have to deal with. We've got the religious health plans, and I don't know if you've been tracking that issue very much, but those are a real concern. It's certainly a concern to regulators, a concern to people involved in the insurance policy side. Healthcare delivery. We did have, not a pre-planning session, but the insurance department and myself and Jennifer did have a meeting with our 4 insurance company representatives in our state prior to this meeting, and asked them to provide some data they'll be presenting today. But during that discussion, we raised some really important questions, I think. All of them are running MCOs in some form, one form or another. And in running those managed care systems, do they see any patterns that don't make sense? that are costing our healthcare delivery system a lot of money. They weren't quick to jump up and say, yeah, I've seen a lot of those, but I'll give you my personal experience. I recently changed physicians, and as I was making my appointment, not with a physician, but with the appointment service for the clinic, I said, well, I'm a new patient. And they said, oh, you're a new patient. Well, you have to come in for a preliminary meet and greet before we can just do a physical, because that's what I wanted. I wanted to change doctors and get a physical. And when I got to the doctor, I said, you know, this requires me to do 2 copays. This requires 2 billing, and it doesn't make sense. I need a physical. And he said, well, I sort of agree with you, so let's do the physical right now. Well, there's a pattern. Now, before you jump to too many conclusions, I think that that's a requirement in Medicare, that they do have that, I think, I'm not sure, but we need to start looking and taking a serious look at some of the things we're doing, we're not doing. And those are just a couple of examples. Jennifer is quick to remind me that our emphasis has to be on legislation. What can we do legislatively that will make a difference? And that's an important point, to keep our focus on what legislation we can do. I can tell you, I'm having it drafted now, that I will be bringing forward to the committee a pharmacy transparency bill that, good, bad, or indifferent, we're going to have the discussion. I was at a national meeting a couple weeks ago, and 2 of the physicians that testified on the panel both made the same comment. They said, you know, there are 3 or 4 drugs I could prescribe to my patient, and I have no idea what the cost of those drugs are. I'm in business. And I'll tell you one thing, if you buy a product from me, I know what the cost is for the service that I'm going to buy to provide to you and bill you on. To me, it's unacceptable that physicians would say, we don't have any idea what the cost is. So we prescribe the drug we think may be best or what, but it has an effect. Barriers. At the same meeting, we had a lengthy discussion about biosimilars. And interestingly, I had Jennifer pull the section of code that deals kind of with biosimilars. And it turns out that we may have some limitations on the utilization of biosimilars in our code. Maybe that's right. But hopefully this committee will look at those kinds of things and make a decision as to what we should or shouldn't be doing. Underwriting lifestyles. It drives me crazy that we have lifestyles that cannot be underwritten. Now, we have to be careful there. I understand it's very delicate territory that we go to. Interestingly, the Affordable Care Act did allow underwriting for smoking. But in our individual market, in our small group market, we cannot use smoking as an underwriting variable. I don't think we can get it changed. Now, it turns out Idaho is working on a waiver, I think, Commissioner, that will perhaps allow states to do that. But it frustrates me. So, do association health plans, do they have a function that they could play relative to underwriting? If so, we need to get at the heart of what's driving healthcare costs, and that's an issue. We need this with your input. I've raised a couple of items. I could have gone on for a lot longer talking about some issues that I'm aware of. But this committee is an active committee. We expect you to share with us and help us focus on what we can look at legislatively that may be providing barriers to delivery and accessibility and affordability, or what things we could do that would enhance those things. And not just give lip service that we all want affordability and accessibility. We need to figure out how we're going to do that. We're going to work collaboratively with the insurance department. The commissioner is going to give a report on their study. That was placed in the bill on reinsurance, a requirement that a study be done. They put the funding for that study in there so they can hire consultants. We're both going down kind of parallel paths, and we're going to work cooperatively. We're going to work cooperatively with the health department, human services, and the insurance department, or any other department, in terms of addressing these issues. And we hope we can get there. The one exciting thing, and I tell people this, and if you go to national meetings where they talk insurance, people are always amazed at what North Dakota can do. We are light years ahead of many states on PBMs. They're just starting to catch up. We are light years ahead on balanced billing, especially for air ambulance. Now, we've struggled with that, and the courts have played a significant role, but we were out there. We had that bill in 2-3 years ago, and we took action. In North Dakota, we're small enough. We've got the right system. We can turn the bills in, have the debate. They may fail, but they shouldn't fail because we didn't do it. They should only fail because it's a bad idea that we came up with. And we should develop those ideas to the point where we can take it to our memberships and get something done. Otherwise, what's the alternative? Universal health. What is it? We cannot, I will tell you this, I will say it publicly, we cannot afford what we have now. We simply cannot. And so this is an important committee. I want to thank each and every one of you for serving on it. Had you heard this speech before you volunteered for this committee? I hope you still stay on. But do not think that you can just sit here and look pretty. We expect you to participate, and I know that we've got the right players on the committee to do the work. So that concludes my sermon on the Mount, so to speak. And with that, we will go to the next item on the agenda, which is a presentation by the Legislative Council staff of a background memorandum on the insurance premium trend study. All of you did receive these 4 studies in an email. I don't know if you've had a chance to look at them, but if you haven't, Jennifer will go over them in some detail. Jen?
Thank you, Mr. Chairman, committee members. Some opening remarks. One, someone will come down and turn our temperature down shortly. 2, there's, like I mentioned, our links are on our agenda. There's a sign-in sheet for those of you who are attending the meeting. I might walk over and get that started so you sign in, so we've got a record of your attendance. Committee members, you'll notice there's a folder in your packet of material. You have this at my request, and CSL put together a packet of innovations in healthcare, and I thought it was really interesting, really good data. Please take that with you, read through it at your leisure. It really is some good material. And then, as Chairman Kaiser said, I did email out a copy of each of the 4 background memorandum ahead of time. The first 3 went out in an email a few days ago. The final one, the one I'm going to present right now, went out yesterday, so you may or may not have time to review it. As I was going through this, you certainly don't need me to read it to you, but as I was going through my memos, I realized it's pretty lean. I put down what I thought was important, and there's not a lot of fat on these. So I'll start going through it and encourage you to take a few minutes if you haven't already and read through it. This is something that will probably be valuable as we go through the interim, and I may refer back to it as we hit some of these areas that we discussed. Additionally, there are appendices for these background memorandum that they're really good. On one that, the background memo I'm going to go over right now with I've got the wrong one in front of me. Not guaranteed, it's the trend. No, I've got one that's, thank you, I've got one that's marked up.
Oh.
Here we go. On the one that you've got in front of you right now, the material that we've attached is a list of how all the different states is the individual market performance for 2018. This is put together by the Kaiser Family Foundation, and it's good material on rates. Okay, so starting off, the reason we've got this study is Section 3 of House Bill 1106, which was the invisible reinsurance bill, included a study of ways the state may be able to positively affect the current trends of health insurance premium rates, with a focus on high risk and subsidized markets. We recognize that we may look at a strict managed care model, and then in conjunction with this study, in the insurance department's appropriation bill was a requirement that the insurance department work with this committee and that they do a survey of providers in the delivery of health care. So as the chairman mentioned in his comments, we will be working quite closely with the insurance department in pursuing this study. The legislative history indicates the goal of the study is to look at the long-term solutions to the problem of the trend of increasing health insurance premium. That goes to the chairman's comments of the trend is the premiums are going up. The reinsurance program comes with a price tag, and there's an expiration on that reinsurance pool. So it's good until next session, where you'll be faced with considering if it's something you want to continue, if there's a different approach that you think might be appropriate. Going to page 2, we look at one of the issues related to the increase in health insurance premiums is the termination of our cost sharing reduction subsidies, or our CSR subsidies under the ACA. Another item we addressed here is the healthcare expenditures. The insurance commissioner testified during the session that a survey of our North Dakota carriers listed prescription drugs, physician services, outpatient services, mental health and chemical dependency services, and diagnostic imaging as being some of the primary drivers for our premiums. In addition to the survey that the insurance commissioner conducted, every 5 years, CMS gathers and reports data on healthcare expenditures, and we've got that data, and there's a list of the different items that they survey. I've included a table on page 2, and it lists in millions what North Dakota lists as hospital care, physician and other professional services, and prescription drug and other medical non-durables. Please recognize that the total in that table is not the total of those 3 factors, it's the total of all the factors they considered, but I hit on the top 3 and listed those for you, and you can see that increasing trend. We talk about looking at a managed care model. During last interim, the Healthcare Reform Review Committee did invest quite a bit of time in looking at managed care for our medical assistance population. Ultimately, they decided to not change our delivery model for Medicaid and our other medical service programs, but we did do a lot of research on that. So if we find ourselves going down that road, we can revive a lot of that. And then we've got our study approach. In conducting the study, the committee will receive the assistance of and reports from the insurance department as the department conducts their detailed analysis of healthcare in the state. And in addition, you might want to consult with our healthcare providers, hospitals, health insurance carriers, PERS, Indian Affairs Commission, and the State Department of Health in looking at information they may have that relates to our health insurance premium trend.
Any questions of Jennifer? Yep, I think that covered it very well. The next item on our agenda is a presentation by Ms. Chrissy Drouard, Health Equity Maternal Child Health Partnership Coordinator for the State Department of Health, on social determinants of health. Welcome. Whenever you're ready, Chris.
I think she's looking for a whole picture.
We don't have a whole picture.
No whole
We don't
picture.
have one right now.
Serious.
Less than one, Chrissy.
Hole punch. I wasn't thinking about it in the interim. Chairman Kaiser, members of the committee, thank you so much for having me today. My name is Christy Gerard, and I am the Health Equity Director for the North Dakota Department of Health. And I am here today to talk to you about the social determinants of health. I don't see my presentation.
I was gonna say, we've got someone from IT coming.
Okay.
We'll wait just a second. Chris.
We've got our presentation. If we can start with the topic, we'll have
The
someone from
audience,
IT.
yeah.
It will be linked on the agenda.
Okay. For folks in the audience, this is linked on the agenda, and we'll try and get the audio and visual up as soon as we can. So, Chrissy, go ahead.
So part of the presentation is video, so I don't know if you want me to wait a minute or not.
Okay, we'll wait. They'll be down in just a minute. Senator Lee.
Mr. Chairman, since we have a moment here, I was going to mention after you said that you may have some barriers to biosimilars. Absolutely. Pharma lobbied very heavily to create those barriers at the time. Unfortunately, more of us were convinced that it was a good idea than that it was not. And so I would love to see us looking at that again. So since you brought it up, if we might make sure that that's part of our review if we have time, I would really recommend that we look at that.
Absolutely. Other committee discussion while we're waiting? I will tell you this, that the cost of biosimilars, and they seem to be equally effective, are significantly lower. And when I say significantly, it can be in the thousands and thousands of dollars. So it certainly begs the question, why do we have so many prohibitions? And I don't know the answer to that. There are so many other areas, Senator Lee, as I look at you, we have scope of practice issues that I hate to bring up, but they do apply. They do apply to the cost and delivery of and accessibility of healthcare in our state. And regardless of whether it's a sensitive issue or not, this is the committee that can discuss it. Senator Madden.
Mr. Chairman, as long as you're talking about general issues, I was thinking of the first study and the study approach. In your preliminary comments, you seem to be quite open to all considerations. But it seems to me our study approach in terms of who we're going to get information from is kind of status quo oriented. If we listen to the same information and providers of information that we have in our committees in all the years past, I'm not so sure we're going to get any movement. So I would just encourage you to think of other persons who could provide input. For example, you noted the concept universal healthcare. Well, is there anybody here who would actually know about that and actually promote it? So I just encourage a broadening of that study approach in terms of who we ask to our table.
Senator Madden, you make an excellent point. If we ask the same people for the same information, we will not hear any alternative. And so we'll do our best at inviting people to participate and try and think of them. So committee members, if you know of somebody that you want to recommend, we are open to it. Representative Cassidy.
Mr. Chairman, on a different topic, which we're discussing is the scope of what we look at. Insulin, the cost of insulin has been a huge concern all across the country. I know the Minnesota legislature is addressing it right now in some type of a way, and I've received emails during the interim already from people in North Dakota and the cost of insulin here. Is that an area that I think we have the scope to do it? Is that something that we could be looking at?
Absolutely. Do we have IT?
Oh, we got life. Sign of the life. I had it started at 1:30, so I was really like proud of myself for being early. And I was like, why is there a meeting already here?
Cody, you're the guy. Cody, before you leave, have any of you ever stopped to think what Cody was like as a teenager? Most of the time, if I need something relative to IT fixed, I have to find a young person to do it. Cody must have been something else. He's something now, but he must have been something else as a teenager. Thanks, Cody. Okay, Chrissy, back on.
All right, thank you. So to start off the presentation, I just wanted to show you a quick word cloud. This word cloud shows many different terms used when talking about the social determinants of health and health equity. Today we will just focus on a few of the terms, but I thought it was important just to see the handful of terms and why it can be so confusing, the subject matter, and how to keep all of these terms straight. So today we are going to talk briefly about the social determinants of health, the difference between health equity and health equality, health and all policy, and what the department is doing to address these subjects. So to start off, we're going to talk about what the social determinants of health are. The social determinants of health are circumstances in which people are born, grow up, live, work, and age, and the systems put into place to deal with illness. These circumstances can have a tremendous effect on one's health, and they can affect anyone, regardless of age, race, and ethnicity. I thought I would take a couple minutes to show you a little data showing the effects of the social determinants of health in both the United States and in North Dakota. For example, 1.5 million individuals experience homelessness, 3.6 million people can't access medical care due to lack of transportation, 40 million people face hunger, and 11.8% of households are considered food insecure. I did include the definition of food insecurity in your pamphlet, but I can tell you that right now. But food insecurity is the limited or uncertain availability of nutritionally adequate and safe food, or limited or uncertain ability to acquire acceptable foods in a socially acceptable way. Moving on to some North Dakota data. An estimated 542 individuals experienced homelessness in 2008 in North Dakota. 22.8% of households were cost burdened. A household is considered housing cost burdened when 30% or more of its monthly gross income is dedicated to housing. Individuals and families whose housing costs exceed their threshold of affordability are likely to struggle to pay for basic needs and forcing them to make some difficult trade-offs.
Mr. Chair?
You got a question?
Yes.
Senator Holt, excuse me.
Thank you, Representative Kaiser. Chrissy, your number on the homeless came from the national study that was corrected a year ago. I think it was nearer to 1,100. You might just want to check that number.
Thank you.
You're welcome.
And I actually found a more updated number on the hunger as well. According to Feeding America, it looks like more like closer to 55,000 North Dakotans face hunger, and close to 17,000 of those are children. And then 9% of households are considered food insecure in North Dakota. And there has been a gradual increase of food insecurity over the past 10 years here. And just to take a second and think about how all of these challenges in these people's lives can impact their health. So why are the social determinants of health important? Only 20% of an individual's health is tied to clinical care, which includes access to and quality of healthcare services. 80% of a person's individual health is tied to their physical environment, social determinants, where you live, work, and play, and behavioral factors, including exercise or smoking. And we can break the 80% down even further. 40% is attributed to socioeconomic factors, 10% to physical environment, and 30% to health behaviors.
Chrissy, before you leave that, and I encourage committee members to ask questions as Chrissy's going through her presentation, but you have here related to access to care and quality of services. Doesn't everyone have access through the emergency room? So what's your definition of access?
Well, access is different for everybody. Not everybody lives next to a hospital or a clinic or somewhere that they can access readily.
Okay.
Each of these areas represented on this slide represent struggles many in our communities face: housing, food, education, transportation, violence, social support, employment, health behaviors, and each one of these can be considered a barrier to good health as well. To improve people's health and well-being, we need to consider these factors and address the social determinants of health. We know social determinants have a bigger impact on persons' health than clinical care. Therefore, we must support practices that address these key issues as a part of successful population health strategy. I included the definition of population health as well in your handout. Population health is defined as the health outcome of a group of individuals, including the distribution of such outcomes within the group. When we talk about the social determinants of health, we need to also think about health equity and equality. Equity and equality will play into how we address the social determinants of health, and this short video explains the difference between health equity and health equality. There's also a link to the video where it can be found on your handout as well.
Meet Bob. Bob lives in a house in Minot. Whenever Bob has a medical emergency, it takes him no more than 5 minutes to get to the hospital. This is Sharon. Sharon lives on a farm in a small town called Max. The nearest hospital to her is also in Minot, 30 miles away. Sharon and Bob have the same doctor who treats them both equally. This is called equality. Equity, on the other hand, is different. Health equity is giving everyone the same opportunity to the highest level of health care that meets their needs. While a doctor may treat someone from a small town the same way they treat someone from a big city, that doesn't mean these people have the same access to the same healthcare opportunities. If Bob has a health emergency, he has a much better chance of getting the highest level of care he needs right when he needs it than Sharon does. The first step to fighting for health equity is to start talking about it. Start the conversation today. Visit ndhealth.gov to learn more.
Representative Castle.
Thank you, Mr. Chairman. You may be getting into this, but being we are a rural state as we are, my hometown is Beulah, so I played Max in high school, where it's at, and where Minot is. But are you getting to, are you proposing, are you asking us to think about everybody has equal access and that's where we have to go? That would be, in my opinion, impossible in almost any state in the nation. So is this just for information purposes, or is this for, you need to be thinking about how we give everybody equality?
This is for information purposes, just for awareness. However, there are things that people are doing like telehealth to increase those services in rural areas as well. So there is access. It's just in a different way.
So access is considered telehealth as well as right beside each other. Thank you.
Senator Lee.
Mr. Chairman and members of the committee, there's been a lot of discussion about the social determinants of health and the kinds of meetings that some of us attend regularly. And one example of that, and Representative Weiss has been very involved in this, is talking about emergency services. We need to make sure that someone who's in a very rural area has access to an ambulance if there's an accident or an emergency. And so that's a part of access to health care. When you mentioned emergency rooms in hospitals, the only kind that they're obligated to provide is if it's truly an emergency service that's needed. It isn't going to be the kind of regular service that we might all think we all want to have. So it's complicated, but access is a lot bigger word than just having a clinic door to knock on. We had a time a couple years ago where there was one psychiatrist west of a line through Bismarck and Minot. That isn't enough to serve all the needs of people who have behavioral and mental health issues going on in the western part of the state. So we have to find new tools, and that's part of our job this time.
So this slide just kind of reiterates what we just saw in the video. So on the top is talking about equality, and on the bottom is equity. So on the top of the slide, there are 4 individuals of different heights and different circumstances, and to treat them all equal, they got the same bike. Well, that same bike doesn't work for each and every one of them. On the bottom, if we're treating people equitably, they all get a bike that works for them, that works for their circumstance, works for their height, so they're all able to ride the bike. So it's putting the video in even more simplistic terms. So how do we make sure and address the social determinants of health and health equity? By making sure we think about health in all policies. The short video explains what health in all policies is, and you will see how the social determinants of health and health equity play into the approach. The link to this video is also included in your handout, and we're going to hope that this works. There we go.
How do you build a healthy community? It's more than our genes, individual behavior, or even access to health care. The environments in which we live, work, and play have the greatest impact on our health. To build a healthy community, it all starts with our environment. We need healthy food, clean air and water, parks for recreation and play, safe transportation for people on foot or bicycle, or in cars or transit, tobacco-free places, indoors and out, affordable homes close to daily needs, communities that are safe and free from violence, jobs and opportunities to invest in our future, healthy schools where our kids can learn and succeed, a feeling of connection with our neighbors, and a strong sense of community. Our health is affected by the places we live, work, and play. But how can we create healthy environments? Experts like the CDC agree that the best way to achieve health is by changing environmental factors. And to create change, there must be policy. Policies provide the framework for building healthy environments. Policies put healthy foods in neighborhoods by financing grocery stores and cutting red tape for farmers markets. Policies create parks and well-maintained places to play. Policies make it possible for us to safely walk or bike to meet our daily needs. Policies ensure we can breathe air free from toxic secondhand smoke. Policies create affordable housing and ensure that our homes are safe and healthy. Policies can promote public safety through well-lit streets. Policies make sure that jobs are accessible by transit and pay a living wage. Policies support healthy schools that kids can walk and bike to, that serve nourishing foods, and that offer spaces where the whole community can play. Individual policies can improve our health in many ways. For example, laws designed to curb tobacco use have saved millions of lives. However, policy doesn't often take health into account. We have made uncoordinated changes to our environment through isolated policies, which prevents us from solving our biggest challenges, such as violence, poverty, chronic disease, and climate change. For example, a Parks and Recreation Department might build a new park, which raises the price of nearby homes. When park policy is disconnected from housing policy, some residents won't be able to stay in their homes. Or the Transportation Department may expand a roadway, which increases the number of cars on the road. Without a policy to design streets for people to safely walk, bike, and drive, community leaders miss opportunities to reduce congestion and improve health. And what if we could change it, working together to tackle our biggest problems? What would it look like? It would mean a new approach, health in all policies. You might call it sustainability or wellness in all policies, or even equity in all policies. But it all means one thing, bringing public agencies together around a common goal. We must adopt a new approach that changes how we make decisions so that everyone is working together to build stronger, healthier communities. This approach requires leaders from public agencies to convene and collaborate, to engage the community and create a vision for a healthier community. to make a plan for how we achieve this vision, to implement that plan by investing in change, and to track progress to see what has been accomplished and what we still need to do. Join the movement to create healthier communities. Visit our website to learn more.
So to talk just a little bit more about health in all policies and to reiterate what you saw in the video, the goal of health in all policies is to ensure that all decision makers are informed about health, equity, and sustainability consequences for various policy options during the policy development process. Identifying ways in which decisions in multiple sectors affect health and how better health can support the achievement of goals for multiple sectors. It engages different partners and stakeholders to work together to improve health while advancing other goals, such as promoting job creation and economic stability, transportation access and mobility, a strong agricultural system, environmental sustainability, and educational attainment. Some examples of successful intersectional collaboration with public health have been implementing water fluoridation, reducing lead exposure, restricting tobacco use in the workplace and public spaces, improving sanitation and drinking water quality, reducing domestic violence and drunk driving, and also requiring the use of seatbelts and child car seats. So just to spend a quick second on what the North Dakota Department of Health is doing right now as far as health equity and the social determinants of health. Well, they hired me in August of 2018 as the Health Equity Director. We have developed the first health disparities report in January of 2019. There is a link in your handout as well for the full report if you're interested in looking at that. For the first time, health equity and the social determinants of health have been included in the department's strategic planning process. The planning process is currently happening. We'll be wrapping up soon, and strategies in the plan will include health equity and the social determinants of health. We went through a boundary spanning grading and layering workshop, and it's a process the department looked at to look at all programs and where there's possible overlap and possible funding to put into health equity. We have been working on developing trainings. We will have an American Indian training completed by the end of August. We've been working on an adverse child experiences training, which should be done before the end of the year. We're working on bringing in a training on personal bias. We also held a health equity summit in April. There is a link in your handout as well that will replay that summit that we had in April. We've been working with CAT Communications to develop health equity and social determinants of health resources. We've been working with Commerce on the MSI Summit, and the second day of the summit will be devoted completely to health. We've been working with a health equity committee that's sharing information about what's going on as far as health equity initiatives in the state in different programs in different communities. And lastly, we have been working on a needs assessment collaboration with various agencies around the state and other areas of the health department on all of the needs assessment processes we've been doing. And in August, we are working with Prevent Child Abuse North Dakota and hosting a day event for an expert to come in and actually speak to us on how important it is to include health equity in all of our needs assessment processes. And this is my contact information on the last page, so if you have any questions that come up later, I would please go ahead and email or call. I'm available anytime.
Representative Anderson.
Thanks, Chairman Kaiser. Chrissy, I would like to go back. I guess when you in North Dakota, you say there's 28,000 over 28,000 North Dakotans that face hunger. Is it the availability of food or the delivery system? Because most of the food pantries that I'm familiar with are stuffed with food, and they end up throwing stuff away that's not used because it gets outdated. So
I can look for that answer. I don't have the answer readily available right now, the exact why. I'm sure it's a new number of different components that add up.
To me, it's the delivery system. So,
but I can definitely look into that for you.
Representative LaFleur.
Thank you, Chairman. Chrissy, thank you for your presentation. I guess I would ask that on your presentation on page 6, could you provide the committee with updated information? You said a couple different figures here. If you could update all those and provide to the committee, that'd be greatly appreciated.
I sure can. Thank you.
Further questions from the committee? Senator Lee.
Thank you, Mr. Chairman and Ms. Gerard. You talked about having a program available for Native Americans, which is great. In my school district, 52 languages are spoken by the children in the district. So what are you doing that would lend itself towards those communities that have a much more diverse population? And in many cases, some very difficult challenges that they have faced even getting here.
It's a work in progress. We started with doing some training on American Indian, as it is one of the largest disparate populations that we have, but we will be continuing to work with other populations as time goes on. We've just started our strategic planning process on what we're going to be doing, so it's going to take a little bit of time, but we'll get there.
Further questions for Chris? All right. Thank you very much.
Thank you.
Committee members, we will go to the next item on our agenda. It's committee discussion and directives. We've had some discussion. Is there any further discussion or directive? All right. Seeing none, we'll go to a presentation by Commissioner Godfrey on the efforts of the department to assist the committee with its study under Section 15 of the bill. And Commissioner, welcome. And I think you have a point or two of personal privilege, right?
Yeah, and I may save those for the end after.
Oh, all right.
If that's okay with you. Thank you, Mr. Chairman, members of the committee. For the record, John Godfrey, North Dakota Insurance Commissioner. Just wanted to give an update and talk a little bit about the study that Ms. Clark walked through and kind of give you an update on where we're at. Now, I imagine you'll see me very, 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 very frequently at these meetings. And so some of the stuff is in the appendix if you've gotten the handout that was prepared by Ms. Clark. But this is the language that was in 1106, the reinsurance bill that was passed. I encourage you all to keep close tabs on that, as I hope we've got some news coming in the next few days. The next piece is from our budget bill, Senate Bill 2010. It's difficult to read up there. It's in your handout. It's also in the appendix that Ms. Clark prepared. This is where the authority is granted for us to go in and work with the hospitals and get the provider data that we've frankly never had. The study we prepared for the reinsurance study that we presented to the Joint Committee of the Industry, Business, and Labor, and as well as this committee as well. Last session, we had some healthcare cost drivers in there. They were denoted again in your appendix and in your handout. Those came from insurance data. So the insurance carriers are required by law to provide us data when we ask for it. That's the data we used. We've always been kind of missing the other side of the coin, what the provider side, the hospital side of that data is. And through this authority that was granted by you all, we now have the ability to go in and do that. And we've also provided some resources to truly do a comprehensive healthcare market study, which is, somewhat to Senator Mather's point. I agree with if the same information is presented time after time, year over year, you're not going to get much change. This will be the first time I know for sure in the history of North Dakota. My guess would be in maybe the nation, that we'll be able to do a full statewide healthcare study, look at that, including both insurance data and provider data. So this is something that we're excited about. We are ready to do. It's going to be a significant lift for sure, but we believe we have the resources to do that, and I'll continue to touch on that as we go forward.
Commissioner, before you leave that point, there is some uncertainty amongst the provider group relative to the authority, and I just would like it on the record. This grants you the authority for hospitals. Does it also grant you the authority for physicians and other individual healthcare providers?
So, Mr. Chairman, and members of the committee, it's my understanding it'd be hospitals in cities with a population of over 10,000. Now, we've had some initial meetings with some of our providers, not all, and I'll get into that with the timeline a little bit. And at this point, we're all in the same sandbox. We're all holding hands and singing from the same songbook, and there's been a significant amount of agreement to work on cooperation. And I think part of that, it's this slide is, it's an opportunity for, again, the providers and the insurers to to tell their story and to again put into data what they may anecdotally know, or I may anecdotally know. It allows us to give us some concrete data to that and behind that. And if the story that has been told is true, then the data will prove that. And so I firmly believe this is a good opportunity for both sides to have the discussion and come to some at least understanding of where we're at, where we exist within our North Dakota healthcare market. It also goes to the point that you mentioned earlier that we're a small state, we're a moderately sized metro area, and if you look at comparatively to other places, but we've got state levers and we're able to do this. And so this comes to us, I think, because we're unique. And it's again one of our opportunities to hopefully be ahead of the curve.
Senator Lee has a question.
Chairman and Mr. Godfrey, North Dakota has resisted the idea of an all claims database, which many other states have. Do you have any thoughts about that to share with us today? Should we be looking at that again?
Well, Mr. Chairman and Senator Lee, I know they're gaining popularity, and they've been in use in other areas. I would probably, I don't really have a firm. I think there's some good data points into it. I think there's probably some bad ones too if you rely on it too much. I wouldn't be, I guess, vehemently opposed to it. I think our carriers may have a different opinion to that, but I can't think of off the top of my head some other points to the all player claim database, but I may have some other thoughts when I collect my thoughts and begin.
Representative Casper.
Thank you, Mr. Chairman. Commissioner Godfrey, on the 1332 waiver, if we receive the waiver, would that apply to all areas of health insurance, the individual market, the small group market, the large group market, and association health plans, or would it be limited to certain types of products or groups?
Mr. Chairman, Representative Casper, the dollars in the reinsurance program itself, the structure is only for the individual market. So it's that's where the reinsurance claims would be happening within that individual market. The tentacles spread a little further because if we can stabilize that individual market, it helps keep the downwards, put some downward pressure on the rest of the marketplace as well as large group, the other areas as well. So the direct impact is to that individual market, and that's where this reinsurance program has been tied, and it's tied to the ACA. That's where the authority comes from.
Senator Hogan.
Thank you, Chairman Kaiser. And John, you mentioned this is a study that other states haven't done. Are there any other states looking at similar kinds of studies so we have some comparison data?
Mr. Chairman, Senator Hogan. Other states have taken pieces. So one notable one is Montana. They self-fund their employees or their state employees.
Right.
They've done a very similar look at just the self-funded employee option, or self-funded plan. They've got that data there. Other states have taken, whether it's Medicaid and kind of look at they've taken segments of the market, but they've never done a broad-based look at it. We'll have some comparisons, I believe, through some of the CMS data and some of those the kind of the aggregate data that they can provide, and so that can provide us some comparison at a high level. But what I believe this study will hopefully bring out and show is, again, more of the detail of what's going on in North Dakota. And I'm not sure there'll be a whole lot of comparisons at that level, but it will give certainly this committee and the future legislature to some things to talk about, I imagine.
May I continue? Thank you. And have you started to think, depending on what the data is, what policy recommendations? It's an interesting question because it's such a new area for us to look at.
Mr. Chairman, Senator Hogan, I've got some own personal thoughts, I'm sure. I'm trying to remain somewhat independent or somewhat neutral on it until I see the data. I'd much rather be making those decisions with the data behind me, and that is part of the study. The part of the study is to bring proposals or recommendations forward to this committee to have some discussion at that point, and whether or not those legislative proposals reach fruition, that'll be up to this committee.
Senator Rourke.
Thank you, Mr. Chair. I'm Commissioner. Trying to process my whole question here. So just having worked for a number of healthcare organizations, having been a nurse now for, I don't know what it is now, 15 years, how will the concept of charity care fit into this? Because when I think about, there's a large variety of prices that are charged but that's not necessarily what's paid. And so how do we consider that into the mix and understand that sometimes, you have to make it all work out in the end? Yeah.
Mr. Chairman and Senator Royce, that'll be a portion of it, and that'll be certainly a point that's discussed, because that is a key driving factor, right? If I show up at the emergency room and I have no ability to pay, there isn't a magic fairy wand that eliminates those charges, and so those get passed on to the rest of us. And I'll segue that into, again, North Dakota has a relatively low uninsured rate. It's not perfect by any stretch of the imagination, but when you look at across the country, we're sitting at 8%, which is again is a good number. And so it'll be a part of it, certainly.
Just to follow up, just an additional piece of information to that is not always the uninsured that are the people who can't pay. Yep. So the insurance may pay a portion, but if you can't afford your deductible, it doesn't matter. So there's still that piece of it as well.
So continue on, the framework and the exact targets of what we're looking at were outlined in the legislation of the authority that was granted a little bit. So billing and payment information, financial information, management and other information, and essentially other information that we deem necessary to complete a comprehensive study. We're still fleshing out some of those targets. We're still fleshing out what that completely looks like. I'd also like to have the opportunity to, again, meet with our provider groups to give them the opportunity to weigh in. I will be the first to admit I'm not a provider expert. I'm on the insurance side of things. This has been housed with us, and we're happy to take this on and look at it, but in no way am I the expert. And so those targets and that final list of what that data call and that data set will look like will have been at least shared with our provider community and for offered some input. It doesn't mean that there aren't going to be any tough questions. It doesn't mean that there's going to be everybody's going to be really excited about sharing all the data. But it's the goal. The goal is at the end of the day to get to a fair look at what this looks like. It's to answer the question again of cost is going up, utilization is stabilizing. What's driving that? And we can point to pharmacies, we can point to pharmaceuticals, we can point to other things, but to get some more information behind that. So if there's policy that can be made at the state level that we can address and drive that cost curve down, because to Chairman Kaiser's point, this reinsurance package is a very good deal for this biennium. It is going to put some significant downward pressure on those individual market rates and hopefully keep more people insured. But the sustainability of it is in question. And whether or not that comes from federal changes or reforms at the federal level that'll help assist states in paying for that cost of the reinsurance program, or if there's other things that we need to do at the state level to allow us to, again, make this affordable or continue to keep this as affordable as we possibly can be, those are going to be discussions that aren't going to stop. And so this study is hopefully to put some light behind it and put some data behind those discussions, so we're at least able to address these in a meaningful way. Jumping into some of the timeline that we're looking at. So also in the handout, I handed out our slides. I also handed out the initial letter that we sent to the hospitals that fit into the target of the cities of 10,000 or more. That gives a nice overview of the legislative history of kind of how we got here. And so that's for your review. Hopefully later today, I'll be signing a contract for our project manager. We're in the very, very, very final steps of bringing on a project manager to help us administer this study. Like I said, it's a significant bite. The person we have that we're in talks with anyway at this point has a significant experience in both insurance as well as healthcare, and comes to us from Illinois, and has done this work or similar work for the governor's office in Illinois, for their chamber, and for like I said, on various sides of the coin. So we've got some good options there for the project manager piece. We'll also be looking at hiring a health data actuary consultant firm that will be able to analyze the data and hopefully help us on the provider expert side of it. We're looking at getting that draft RFP done by August 15th, so very quickly here. in August and September I'll be going out and meeting with our providers to hopefully, again, have some introductory discussions and again, instill that we're trying to make this as fair as we possibly can make this. I'm not coming in with any preconceived notions. I would like to see what the data comes behind it. September 30th, we'll have a kickoff meeting, hopefully with our health actuary, to discuss, again, the data sets and the data call. October 15th would be another good update with our management plan and the data progress. November 1st to December 31st is what we tentatively timeline for the actual data collection period. February 1st would be our completion and drafting of the final report. May 1st through July 31st would be the finalized report, and hopefully bringing forward to you somewhere between that July 30th, 31st to November 30th timeline to close out the study officially and bring forward recommendations and proposals to this committee for your consideration. So this will be, like I said, this is going to be a significant lift for us, which is why we are happy to have the resources to be able to bring on a project manager who can help us assist through getting this stuff done. We learned a lot with our reinsurance study. A lot of that individual discussions with the actuaries and with us felt that Jeff Ubin, who's our deputy and general counsel, and it took up a significant amount of his time, which drew him off other projects as well. So I'm hopeful that we'll have experts on both sides. We'll have experts that will be able to handle us and walk us through this. And also there's a level of independence then too. So there isn't any bias, hopefully.
Senator Madden.
Mr. Chairman and Commissioner, a very aggressive timetable. Appreciate it very much. I'm wondering, in terms of the possible action steps, would you see those as being from the consultants that come in, or would they be from the insurance commissioner, or would they be from the providers? And everybody's going to have a little different point of view. From what perspective will the action steps come to this committee?
Well, Mr. Chairman and Senator Mather, I believe they'll probably come from, initially probably from the consultant, right? They'll have done their review and looked at the data and said, here's some potential areas where you can bend that cost curve down. The finalized recommendations will be coming out of my office. But at no point will there be any, I'm sure, lack of input on either side, the provider side or the insurer side. And so ultimately that's, I think, in order to bring you, this committee, hopefully a plethora of options and allow the policymakers to make the decisions on what's the best route to move forward. Some of these recommendations may not be legislative. They may be other policy initiatives that either on the provider side or on the insurance side. That's one of the benefits, I think, of housing the study in the insurance department is we're able to take a look and recommend those type of policy actions as well that don't necessarily have to be crafted in the form of legislation. So I'm hoping we get a nice mix, and I'm hoping you'll have a very good discussion. Like I said before, our providers have the few discussions I've had are excited about this opportunity. Our insurers are excited about the opportunity as well, and we certainly are ready and willing. It is an aggressive timeline for sure, but a lot of this data should be readily available. It should be a matter of sharing it with us.
Further questions?
Any other questions? I've got one point of privilege that I'd like to offer, Mr. Chairman, if I could. Many of you have gotten to know Deputy Commissioner and General Counsel Jeff Ubin over the last number of years. He's been here longer than I have. I just wanted to inform you, so there is no surprises, that he'll be departing the insurance department. It'll be around the end of this month. We are in the process of filling those very, 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 very big shoes, size and skill. But it's been a pleasure to work with Jeff. It's a pleasure to serve with Jeff. I've got to give a lot of credit to Jeff and the 2.5 years that I've been on as insurance commissioner. I wouldn't be near the position of insurance knowledge or or anything in that nature without him and without his support. So I think we're picking an okay time to make the transition. Our reinsurance bill or stuff is kind of come to a completion of what we can do at the state level. We're just starting a new study, so hopefully we've got a nice transition time here where we can. But I just wanted to make you all aware and that as of end of August, Jeff will no longer be with us, and he's moving on to bigger and better things, I think. So
I'm not sure better or bigger, but he is moving, that's for sure. Thank you very much, Commissioner. I just want to say, Jeff, on behalf of the committee and legislators, it has been an honor and a privilege to have worked with you on insurance issues. For those committee members who have had that privilege, Jeff has always been really open, critical in a positive way when appropriate, and kept us on point. He will be sorely missed. He has a lot of information, institutional memory, and that sort of thing. And lastly, Jeff, I don't remember signing a dismissal slip. So as far as we're concerned, you're still here. But no, we will miss you, Jeff, very much. So.
Thank you. I've enjoyed working with all of you as well. You've been wonderful people, and hopefully we'll be seeing you down the road sometime too.
Is there a mic?
Not give him too big of a head. No, he's been great, and he will be missed. I do want to. I've got a couple minutes. I'm ahead of schedule too. Just offer an update on the air ambulance side, if that's okay, Mr. Chairman. In your opening remarks, you mentioned that we were light years ahead of many other states on how to handle this inter-ambulance issue and this balance billing issue. For those of you who stay up late and read the Senate reports or the congressional reports, there is some movement on the balance billing side of things. Many other states deal with the balance billing issue, and the commonly used analogy is you go in for your surgery, you come on, you receive a giant bill because your anesthetist was out of network. There's no way of knowing that. You go to the same hospital, it's in network, you've been going there for years, and all of a sudden one of the providers that works on you when you're unconscious is out of network, and you have no way of knowing that, and you get a giant bill. Congress has been very, very interested in solving that problem. That problem doesn't necessarily exist to a large degree here in this state, yet not saying that it couldn't. But 99% of our providers are in network with our carriers, and we all operate like the state we are. The big issue that we've had that's been carved out is air ambulance. Air ambulance has been an issue for the state, for many rural states. It's a similar thing where they'll be out of network. They'll take a ride when you're unconscious to the hospital to get saved or hopefully get some life-saving treatment, receive a $30, $40, $50, even $80,000 bill on the back end because you had, not for a choice you made, not for anything due to your own fault, but just because the air ambulance provider is out of network and the luck of the draw on who got called happened to be an out-of-network provider. In 2015, this body passed a bill that would have instituted a priority call list. That's kind of the low-hanging fruit. That seemed to make a lot of sense. Why don't we just do that? You all did that. That was overturned in the courts due to the Airline Deregulation Act. Air ambulance companies are able to be shielded under the Airline Deregulation Act from any kind of central regulation. 2017, we came back and took another run at it and put some language in all of our healthcare contracts that said any out-of-network air ambulance provider would be reimbursed at the average of the in-network providers. We've got 9 air ambulance providers in our state that are operating, or that primarily operate in our state. The vast majority of those are good actors. They're either in-network or we don't have a balance billing issue with them. We have a couple that are not. And so we addressed it through the 2017 legislation. We believe that as the insurance department and under McCarran-Ferguson, which is another federal law that gives states the sole authority to regulate the insurance marketplace, we have the standing to do this, put this in the insurance contract. We believe that's within our purview. We were challenged again by one of our providers. That law was overturned in 2018 in district court here in North Dakota. We are appealing, and we are likely going to be in oral arguments in front of the 8th Circuit at some point in hopefully this fall. We believe we got a shot at the 8th Circuit. There's I'm going to get super legal nerdy on you. There are 2 tests that you have to look at, a Perino test and a FABE test. The 8th Circuit has looked at both. They've used both. So the circuit is split on how to handle that. We need to have them use the FABE test. Our district court here in North Dakota used the Perino test. Under the FABE test, we think we get a favorable ruling. And so we think we've got a fair shake at the 8th Circuit with the circuit split. Either way, I would imagine, no matter what the outcome, there will be a writ to the U.S. Supreme Court to solve this problem. Depending on if they take that up or not, that's going to be up to the Supreme Court. But Congress is currently looking at some language that mirrors the North Dakota language from our 2017 law that sets a median rate for a geographical area. So very similar to the law that was passed by this body in 2017. We have encouraged our senators and our representative to push on this issue as hard as they possibly can. As you can imagine, the air ambulance industry is very, very, very much opposed to this because as it stands right now, the bad actors can charge whatever they want and you got to pay it. And there's really nothing that anybody can do to stop it. And so they're spending a significant amount of resources to keep that golden goose in play. And so just wanted to give the update there. We were hopeful that the Senate bill, the Lower Healthcare Costs Act, which includes the language we like, was going to be voted on before the August recess of DC. That likely won't happen. It'll hopefully be right when they get back. As with Congress, we all know the delays happen. The House version right now does not have any air ambulance language in it. So we've been working with Congressman Armstrong to advocate for that and push for that. We believe there's an amendment that's out there that will likely be introduced, or a standalone bill that similar to the Senate bill but has an arbitration clause in it where the insurance carriers and the air ambulance providers have to enter into arbitration. It gets the consumer out of that mix, which is a good thing. But as I know some of our carriers can talk, that arbitration can be lengthy, drawn out, and end up costing more than any settlement would have ever cost. They're aggressive. And so any support you can offer on that, like I said, it's nice to see a Senate bill that has North Dakota language mirrored in it. There should be some credit. Representative Anderson worked very hard on that bill as well. So we believe that's a good policy move that hopefully Congress will take up. And it's a bipartisan issue. It's a nonpartisan issue. And it actually impacts our consumers. So just a real brief update on that. I'm happy to answer any questions on really anything insurance related. It's what I love to do.
Any questions from committee members?
I'd like to make, Mr. Chairman.
Yeah, Senator Miller.
Mr. Chairman and Commissioner, I couldn't help but keep staring at your study guideline. And I'm a little bit worried about the closeout of the study. Our committee, if we get material much past September, it's been my experience we haven't been very useful in making a good case to the legislature coming up. So anything you could do to help us get that in that July-August framework would really help the chances in the next session.
So, Mr. Chairman, Senator Mather, in a perfect world, as you can see on here, the February 1st to April 30th is the draft of the final report. I wouldn't be opposed to having probably some very detailed updates to this committee that would hopefully give you what you need. Because we ran into the similar issue with the reinsurance study. That we got started late on that, and it took a significant amount of time, and we barely made the September meeting, and not enough time for the 2-reading rule to have any. So we're very aware of that, very sensitive to that, and we're hopeful to have something on this committee's by early summer next year.
Good point. Any other comments or questions? Commissioner, thank you very much. Great job.
Sure.
Any committee discussion at this point? Seeing none, we'll go to the next item on the agenda. Are there any interested parties in the audience that would like to comment on anything that has been covered to this point? All right, seeing none, we will go to the next segment of our program, which is a panel discussion by our 4 health insurance companies that provide coverage in our state regarding drivers affecting health insurance premiums. Would ask those folks to come up to the table to preside. I'm not going to take the time to introduce you. I'll ask you to introduce yourself, and I hope you've had some discussion amongst yourselves on who's going to start. I can certainly pick someone, but you can go on both sides if you wish. Or on one side. We have the names. Have you selected anyone to start? All right.
I'm Tony Pashone.
You need to turn the mic on. And, yeah, there you go. Thank you.
Okay. I'm Tony Pashone, Vice President of Actuarial with Blue Cross Blue Shield of North Dakota. I've been with the company for about 4 years, and before that worked for another Blue plan for about 15 years.
Mr. Chair, members, my name is Manny Munson-Rodala. I'm counsel for United Healthcare of Minnesota, North Dakota, and South Dakota. Glad to be here.
Chairman Kaiser, members of the committee, my name is Molly Carmody. I'm a senior legislative affairs specialist with Sacred Health. I have about 3 years of health plan experience and 3.5 years in total with Sacred Health.
Mr. Chair, members of the committee, for the record, my name is Matt Schaefer with Medica Health Plan.
Chairman Kaiser and members of the committee, I'm Chelsea Matter. I'm Director of Provider Engagement at Blue Cross North Dakota. I've been there about 8 years, but I've been in public health and healthcare before that.
Okay. Who's going to start? Helping us understand. You can sit right there if you wish. We want you to feel very comfortable.
Do you have?
Oh, if you,
should I?
He's got slides to do.
Okay.
Might be easier for you.
Yeah, you can go to the lectern, if that will help.
I'm sorry.
Chairman Kaiser, member of the committee. Again, my name is Tony Pashone, VP of Actuarial. And I am here to share some information with you on the rating process. And really, I'm just here to, any of the carriers could have been up here. I'm going to share information that would be more general for the whole market, but I've been appointed the one and happy to do this to share this information with you. And then I kind of want to cover some just foundational items and then talk about kind of how we develop rates. So just to get everybody kind of to the same understanding of our rate development process in the market, because I think as the committee is trying to make decisions about what to do to address costs, it's important to know how that ultimately flows through to the premiums that people pay, which is really what we're trying to address. So that's really the purpose of my presentation, is to set the stage for what everyone else is going to talk about. So, and one other comment I would have is, I think it's good I think there was a comment earlier about, getting kind of a broad perspective on what works and what doesn't work in the market. And I think that's really helpful. As I mentioned, I've been here for 4 years. And I previously lived in Indiana and worked in that market and some other markets. And, I think it's good to look at what is happening in the market in general, but then, when it comes to solving problems, I think it's important to look at, what North Dakota data and North Dakota issues, because I think the issues that impact this state might be different than what impacts other states. So again, I think it's good to look at, national data and national premiums and costs, but I think it's also good to hone in
on North Dakota, which I think the insurance department, is kind of leading that charge in a lot of areas. So I think that's a good approach. So first, before I kind of get into the rating, I just wanted to, this is kind of a reminder just of the basics of insurance, because I think, health insurance is a very personal product for a lot of people. It's different than your homeowner's insurance or your auto insurance, but it is insurance. So there's some sort of pooling of risk in different populations. So when we're setting rates, for the most part, individual rates are based on the individual pool, and small group rates are based on the small group pool, and large group, and on and on. So, there's subsidization within each of the pools, but small group isn't subsidizing individual necessarily. And, they each kind of need to stand on their own, which means they all kind of have their different challenges then as a result of that. But I think it's important to keep that in mind. And again, just, from a subsidization perspective, some people pay car insurance or homeowners insurance for years and never have a claim, and other people have, frequent claims, and the same is true in health insurance. Some people are benefiting a lot more than what they're paying in, but they're paying their premium for the security, knowing that they have that coverage when they need it. And some people, have significant health issues and need to access the system more frequently. So,
Tony, before you leave that chart, and you may be getting to it, the previous chart, when your companies pool risk, I understand you have the small group, the individual market, et cetera, but within that, you have sub-criteria. Are you going to get into those?
Okay, I will get into that, Chairman Kaiser, if that's okay. Yeah. In a couple of slides. So now just, having kind of set the stage with the foundational insurance concepts, what do we mean we're talking about rating? You'll hear that term a lot in the market, and, what are people talking about? Well, it can take on multiple meanings, and I wanted to list a couple of them here, but on the fully insured side, which is a lot of what we talk about, it can mean, rating a line of business like we talked about, the individual population or the small group population, et cetera. And that is supported by rate filings that get submitted to regulators like the insurance department and CMS. Another kind of way that the rating term is being used is more related to kind of the renewal or new business underwriting side. So how do we calculate updated premiums for individuals or groups, within that line of business, within the individual market or the small group market? And really, we're applying everything that we filed with the regulator. We're applying all the methods and factors, and everything that was applied or that was filed with the regulator then gets applied either, at a member level or a group level to develop the rates. So I'll first probably spend most of the time on the fully insured side, but then later in the presentation I'll talk about self-insured and how that's a little bit different, but we won't spend a lot of time on the self-insured side.
Tony, we have a question. Representative Katz.
Thank you, Mr. Chairman. Tony, how do you determine the medical trend for an annual basis on renewal factors?
Chairman Kaiser, members of the committee, I guess, can I come back to that question? I mean, let me answer it briefly, but I don't want to get too sidetracked on that specific item. I mean, we're looking at a lot of different factors. We're looking at, the cost of care, what kinds of, unit cost increases. An office visit doesn't cost the same in 2019 that it cost in 2018. So how does that contribute to the overall cost? So there's the unit cost aspect. There's a utilization aspect. Are people accessing care more frequently than they did a year ago, or whatever that comparison period is? And then finally, mix of services would be another consideration. New technology, causes new services and sometimes more expensive services to become more prevalent, and that affects kind of the mix of services, even though the actual number of services might not change significantly. So I guess those are just a few factors. I hope that answers the question. So kind of getting into the line of business rating. So again, thinking about like the individual market specifically or the small group market, what kinds of things are we looking at when we're setting the rates? And it's really not that these are simple, but it's really fairly, when you just list out the items, it's a fairly basic algebraic approach. So we first need to project the claim costs. So we're taking claim experience from some past period and projecting it into the future. And I highlighted that item because that is the biggest cost driver or biggest contributor to what the premium will be in the future period. And I'll have a pie chart in a few minutes that'll show that. Secondly, what types of adjustments do we need to make to that experience? For example, in our base period, maybe there were products available that aren't going to be available in the future, or maybe there are new products, or maybe there are new benefits that we need to cover that'll impact costs in the future, and those need to be adjusted in calculating kind of an adjusted claim cost. So now that you have that adjusted claim cost, then you need to layer in kind of all the other costs. So, administrative expenses for the insurance company, and this includes a lot of different services, claim processing, care management, wellness programs, a lot of the things that the other presenters will probably talk more about in a little bit. And those things vary by line of business and company. It's more expensive to administer an individual product than it is a group product because you're touching each specific insured as opposed to your main customer being the HR group from the HR from that customer. So the individual is more expensive to administer, and we have to layer in state premium taxes, which are 1.75% in North Dakota. Add in ACA fees, which are again kind of set by regulation, and then finally reserves, which you can use a lot of different terms. It's reserves or contribution to capital. That again is going to vary by line of business and company, as far as what companies have, what the targets are for a specific company, or how important is a particular line of business to a company. They may be wanting to get, they may be willing to take less margin on it, I guess is what I'm saying. But at the same time, insurance companies have minimum capital requirements that they have to maintain. So some contribution to surplus is necessary, especially as costs continue to go up. And then finally, the competitive environment is another consideration when rating by line of business. So now just getting in a little more detail on the kind of the renewal underwriting process, the other type of rating that falls under the fully insured bucket. So this again is where you're rating for a specific individual or a specific small group or large group. So on the individual side, for the most part, we don't have underwriting anymore as a result of the ACA. So we're calculating kind of that rate or the rates that we need as a pool in total, and then they're split out by product and age. So how much do you need to collect to cover the whole pool, and then how do you divide that up by product and age? And in the ACA case, the age curve is set, so that's another factor that's pretty much set by regulation. So here, if you think about subsidization, you could have two 25-year-olds that have the same product and they're going to pay the same premium because there's no underwriting. Their claims experience could be vastly different. One could have no claims for years, and the other could have high dollar claims every year, but they're going to pay the same premium because there's no individual underwriting anymore in the ACA market. So that's individuals kind of the extreme case, I guess, when you think about subsidization across the pool, where people individually with the same age, same product are paying the same rate. When you get to the small group side, it starts to get a little more specific as far as you're still rating the whole pool, and you're still varying the rates by product, but then you're also introducing often some demographic factors to, like the family composition or again age. So it's similar to individual, but slightly different. But still not, on small group, you're not using a group specific claim experience to develop their rate, because there's a lot of fluctuation in rates at a small group. If you think about a small employer with 10 employees, their claims are going to fluctuate a lot from year to year, and you don't want that to be reflected in their claims. So, the pooling kind of helps smooth that out. When you get to larger groups, that's where you're using more group-specific claim experience. So there's a little less, I guess I would call cross subsidization within that pool. Outside of some, you often will pull out very high dollar claims and spread that cost over the whole pool, so that maybe no one group gets hit by its own high dollar claims from one, and that fluctuation from year to year. So the point there is that it is starting to get into more specific, where the rates are based on specific claim experience for that group, and PERS would be a good example of that, where the PERS rate is based on the experience for the PERS group. And then in the in-between areas, kind of the medium-size groups that are kind of a blend of that small group approach and that large group approach, and that blending depends on where they fall in that spectrum. Are they closer to being a small group, or are they closer to being a large group? If they're closer to a small group, then it's weighted more toward the small group approach, and if they're closer to a large group, it's weighted toward the large group approach, which would use that group's experience at least in some fashion.
Tony, if you were providing the service for a large self-insured plan, would you use different underwriting for just managing the self-insured when you came to making a recommendation for the rate for next year than you would in a large group which is fully insured?
Chairman Kaiser, members of the committee, the approach would be very similar. I think there's, as far as projecting the claims in some fashion to that future period, that would be similar. What types of administrative costs you need to layer in, and then what kinds of taxes and fees apply to the self-funded business. So I think the thought process and approach is very similar. The components of it might differ, as far as maybe some of the ACA fees don't apply to the self-insured market, or premium taxes don't apply to all of the cost of in the self-insured market. So there's some differences, but the general approach would be pretty similar.
But you would not use the profit that the company would hope to achieve. You would certainly have the servicing fee.
Well, Chairman Kaiser, there would be a component of that somewhere in the process. So self-funded groups will often have stop loss coverage to cover those high dollar claims, and there would be margin built into the stop loss premium. And I have a pie chart that gets into that a little bit too later on. So this pie chart is just kind of breaking down that fully insured premium into the different components. And I know the print is a little bit small on the legend there, but the dark blue large piece of the pie is medical claim costs. The smaller blue piece of pie is the drug claim cost. The orange color is the administrative expenses for the insurance company. The yellow are the taxes and fees, the premium taxes, ACA fees, that type of thing. And then the gray would be the reserves or surplus or contribution, capital, margin, whatever terminology you like to use. So, the point of this is to show, and the size of these slices would vary from line of business to line of business, or company to company. That's not really the main point. The main point really is to show, it's really about the claim costs. The medical and drug claim costs are by far the big chunk of the pie. Administrative expenses are also part of the picture, and then taxes and fees and margin. So when we're focusing on, and then I'm sure the other carriers will talk about, we're focusing on how to, make insurance affordable. That's about managing the claim costs. So now, after covering kind of the fully insured side, I was just going to briefly cover self-insured. And again, as I mentioned, it's pretty similar. So on the self-insured side, the main goal is to just estimate what you think the funding need is for that particular group for the next plan year. That's really what you're trying to do, but the process is very similar. So when you're doing that, you want to estimate what those future claim costs, what you expect them to be, what administrative fees are going to be charged by the insurance company, which could be per member or per contract or a percent of claims. And then most of the self-funded groups have stop-loss insurance, except for probably some of the very large ones might not purchase it, but most companies these days do have, or most groups these days have stop-loss insurance. So you add in the stop-loss premiums and then add those three items together to really get the total costs. And that determines the expected funding level for the group for the next year. And again, the difference is that's the group's liability. The carrier's liability is any of the stop loss claims that they incur in the next year. But most of the cost is borne by the group. And the pie chart on the next page kind of breaks that down. So it's very similar to the fully insured pie chart that we looked at earlier, where we have kind of the medical is the largest piece and the drug claim cost is the second largest piece. Again, there's a administrative expense component for the carrier. There is actually a taxes and fees item, even though it's actually a tiny sliver that you actually can't even see on the chart, but there is a component of that. And then finally, the stop loss premium is that sliver that you can see, and that's the stop loss premium that the carrier would charge to take the risk above a certain claim level. And there would be a profit component in that stop loss premium.
Representative Castle.
Thank you, Mr. Chairman. Tony, is there a percentage of the actual cost on this chart that is typical for stop loss insurance premiums? Because I notice your slice on this chart is very small compared to what I've actually experienced as far as the cost of stop loss insurance to the whole cost of the chart.
Chairman Kaiser, representative of the committee, I would say that varies a lot. It would depend on how much risk the group is willing to take. So if they have a stop loss attachment point of $20,000 on a particular member, then the group is shifting a lot of the risk to the carrier in that case, because they only have responsibility for the first 20,000, and the carrier is going to charge a high stop loss premium for that coverage, as opposed to the situation if the attachment point is, say, 200,000 on a particular member, where the group is accepting the first 200,000 of the liability on any particular insured, and the carrier is taking the rest, then it's a smaller sliver. So this pie chart is picturing more of a kind of what a larger group would have, how the costs would break down for a larger group. If you were to do the same chart for a smaller group, you're right, the stop loss slice would be bigger.
What's your definition of larger group? How many employees or units?
Chairman Kaiser, members of the committee, I don't know that I would put a specific number on it. I mean, it's really about the stop loss risk level that the group is willing to take. Is it 200,000 or 50,000 or 500,000? I mean, that's really the determining factor. As I said, I use the term the larger groups because larger groups usually are willing to take more risk on that component than a smaller group would be able to do. So that was my distinction there. But it does, different groups make different decisions about what level of risk they're willing to take on from a stop loss perspective. So really that concludes my portion of the presentation. Unless there are questions, again, I just wanted to kind of run through some foundational concepts on insurance and the drivers of premium at a high level, and then I think the other presenters will get more in depth into specifically on the claims side, what do they see and how do they try to manage those costs.
Any questions from the committee for Tony? Tony, one last question, for me at least, and that is, do you have a dynamic model of those pie charts? I mean, I'm not sure what the point in time is for this pie chart, but we hear on the national news and other sources that the cost of drugs is dramatically impacting the cost of healthcare. Do we have some kind of demonstration as to what's happened to that slice of the pie? over the last 5 years.
Chairman Kaiser, members of the committee, I don't have anything here. I probably could put my hands on something that's publicly available and, that divides up that cost a little bit and shows kind of how that's changed over time. And I just, like you said, mine was more of a snapshot in time and would vary depending on the line of business or carrier.
Thank you very much, Tony. Who wishes to go next?
You can just hit F5 if you want. That works too. Can't find it.
All right, thank you, Mr. Chair, members of the committee. My name is Matt Schaefer with Medica Health Plans. Can folks hear me okay? Terrific. Well, for beginners, as I move through our slide presentation, a lot of the material that I was going to cover, if I'd say the first 5-6 slides were largely covered pretty well as the chair and Ms. Clark and then Mr. Pichon were setting the stage. And so I might move through those a little quicker. Those are relying largely on mathematical data, on national data. And then we'll move a little bit into utilization and talk about from the perspective of really how it's affecting your constituents, what this really looks like for patients. When we look at cost drivers, really they fall in 3 categories. We're talking healthcare costs, which aren't surprising. We're talking drug costs, which have been alluded to a couple times, and I know other panelists are going to talk a little bit about that. And of course, utilization. And these are all 3 items that affect costs. They're all going up in different manners. And I'll shed a little light on what we've seen nationally, and then we'll get a little local pretty quick. Now, a little background on Medica. We've been in North Dakota for going on 25 years, and we are currently in 46 of North Dakota's 53 counties. In looking to increase costs, we saw some significant increases in 2014 and 2015. I think a big piece of that is that's when you start seeing a large number of new individuals coming into the individual market, and there was some pent-up demand. And so that's where you start seeing some of those double-digit increases and those significant premium increases across the country. Now, costs are still going up, but they're not quite going up at that same rate that we were seeing through those years. And that was predominantly in the individual market. Now, conversely, in the large and small markets, we saw pretty steady growth, and that really kind of was a good barometer for looking at what healthcare costs were actually doing, as opposed to looking at that impact that utilization had. At the same point, we also saw some significant increases in drug costs, and those by and large followed the same trends you saw with medical costs. A big attributor to that was largely with the increases in prices of specialty drugs. We saw some new products coming on the market. We also saw some pretty big increases with specialty products that were already on the market, right around between 30% in 2014 for some hepatitis C treatments, as well as some oncology medications. And I want to be clear, these are medications that do good things. These are medications that make sure that we can spend more time with our loved ones. They're giving them a new lot on life. That's what folks are paying for when we look at that. Another trend that's taken place is the percentage of pharmaceutical costs that are paid by insurers has progressively been going up as well. In this slide of the presentation said it was about 80% of what a carrier is paying out in claims. I'd say that number's gone up a little bit since 2015. In addition to that, I'm going to move over and really give you a sense of what that looks like when you look at a disease-specific data. And this is a place where it pulls some information from the American Diabetes Association, the CDC, as well as from a report that the North Dakota Department of Health looks like you periodically do one on the state of diabetes. And this one lays out, you see the cost here in care progressively increasing over the period of 10 years. You also see how the cost of insulin has progressively gone up. But I also want you to take a look at that last number where you see the diabetes incidence is also progressively going up. So that's what's happening when we see those numbers going up. It's not just prices going up. Our neighbors are needing treatment as well. And that's when you get into utilization. One of the stats you've heard before is about 1.3% of our population is really making up about 19.5% of that medical spend. Now, who are these folks?
If you go back.
Oh, absolutely.
You said something, and then I was hoping that this slide was going to answer my question, but it didn't quite. You made the comment about the fact that as insurers, you guys have been picking up a larger percentage of the cost. So can you explain to me how that would fit on this slide, just so I want to make sure I understand. So like as the price went from 75 to 130 to 275, you're saying that you essentially did not pass that increase, as much of the increase onto the consumer and the insurance company, a higher percentage of the cost? Is that what I was hearing?
Mr. Chair, Senator, that is correct. As time went on, we have been paying more of the price on this medication than what we traditionally have in the past.
Thank you.
Now, the other piece I want to say is so essentially, who are the folks that are using up 20% of the services? Some of the things we know about this population is they have at least one chronic condition, and it's going to be one they're going to have for the rest of their life. There's about a 30% chance that they either have cystic fibrosis, multiple sclerosis, and slightly below that's HIV. There's about a 20% chance that they have at least one type of cancer. Lung, breast, or colon are the most common. And these are diseases they're going to need treatment for basically for the rest of their lives. So these aren't costs where we can really get in and do an intervention. So one of the trends you've seen a number of payers taking on, and I was going to talk a little bit about this, are accountable care organizations, also known as ACOs. Now these are essentially narrow network plans. This is not one size fits all. This is one size fits a portion of the market. And really what it gives us the ability to do is partner with the health system and offer consumers a product with a lower premium than what you would get with a broader network. You're making the commitment to really go to one healthcare provider for the vast majority of your services. Speaking a little bit about Medica, we have 2 ACOs that have a footprint in North Dakota. One with All True Health Service System, which is over in the northeastern portion of your state. And then there's also in the southeast, we have Essentia Healthcare. Now, in addition to with partnering with that system, you also have access to our standard networks for chiropractic, behavioral health, and pharmacy. And essentially what that's allowed us to do is really try to figure out what patient behavior is going to dictate and basically whether we could derive any savings. And when we went out into the field, who's been more interested in this? Not surprisingly, folks who were younger, healthier, with fewer healthcare needs, it was easier for them to make a commitment and say, yeah, I can go to Essentia, or yeah, I can go to All True for most of my services. For folks that were slightly less healthy, or their provider did not work in that network, or for example, maybe they have a doctor that provider just doesn't have much of a presence in their community, then they probably went with a broader network product. We ended up with a slightly healthier population in the ACO group, but we did have a good enough case mix that as time has went on, we've been able to track data and evaluate what the behavior looks like and the treatment looks like. We're seeing savings. So with healthier users in the ACOs, we do see a modest increase in utilization. It's about 2%. That's getting your flu shots, that's your preventive visits. But if you look at the low to moderate to high to very high utilizers, then you start seeing a progressive decrease. And a big piece of that is cutting down on emergency room visits. It's cutting down on urgent care visits, and it's really placing a higher emphasis on care coordination. And I want to emphasize, these aren't kind of top-down, one-size-fits-all agreements that we reach with providers. We really want to work with them and work together to find something that's going to make the most sense for the patients. We might build in incentives for us to make sure we're doing a good job on our part. We'll build in incentives to make sure that they're managing these patients' conditions better, so they're having better outcomes, and we are trying to bend that cost curve. Now, the other number I wanted to show you is, as I mentioned, these are 2 different health populations. The top number shows you those net changes that you see, but if you look at that second set, those net savings are actually risk adjusted. So if this was an apple-to-apples comparison of 2 exact populations, we were still seeing a minus 11%, or an 11% savings for our folks who were going to an ACO. And the last piece I wanted to leave you with is, as I was talking to some of our product design people, if they had any advice for the committee, and I said, make it politically incorrect, make it something that might be, as you're looking at this, what are your recommendations? There were 2 that kind of came up as conversation starters. So I'm not going to say we have the answer, but we are going to say that it's a question to ask. And the first one is talking about transitioning out of outpatient care. We've seen the migration from inpatient to outpatient, and now it's worth asking the question, what services are taking place in an ambulatory surgical center that could be taking place at home, or via telemedicine, or via maybe in your doctor's office, where you're not being stuck with all that overhead that's going into keeping an ambulatory center running. The other piece is dealing with drug costs. I know some of the other panelists are going to get into this a little bit more. But one piece was really addressing high utilization when we see that it doesn't line up with the evidence. This is a place where we did quite a bit of work in the opioid space. We actually reached out directly to prescribers who we could see from the data, you're prescribing a lot more opioids than your peers are, and you've got the same patient mix, and it looks like it's not following evidence. And in having those conversations, 99 times out of 100, the provider says, thank you. Let's look this over and let's figure out if there are ways that we can change the prescribing habits and also try and basically find another way to manage that patient's care. And the last piece is managing your PBM. For us, our health services team has actually a couple senior folks on staff who came from the PBM industry, and it's very important to us that we make sure this is a vendor that we're paying for a service, and we will make sure that we're maximizing our members' benefits. That is all that I have, and I'm happy to answer any questions.
Thank you very much, Matt. Any questions from committee members? Representative Casper.
Thank you, Mr. Chairman. Matt, you just brought up my
I heard that might happen.
Thank you for the opportunity. Does Medica, have you made a decision to begin to utilize totally transparent PBMs in light of congressional investigations and the cry across the country for what is being discovered that PBMs have been doing and are doing, or do you like to use the traditional PBMs, or are you doing both?
I hope you understand. When you say totally transparent system, Representative, what does that look like? Let me make sure I
Totally
understand.
transparent would mean no spread pricing. 100% of the rebates are passed on to the employer. It's really a fee for service. We will charge you a per member per month fee to manage your prescription drug spend, and that's what our costs are, and nothing else is charged unless we disclose it to you. So it's total disclosure to the employer who pays the bills.
Mr. Chair, Representative Casper, we use a combination, and the big piece I can tell you is basically 98.5% of our rebates go directly into premium relief. So anytime we see different legislative proposals that either intentionally or unintentionally result in fewer rebates per se, that's where when we're looking at the claims, we're trying to figure out if we're going to be able to provide the relief we were in the past. Having said that, we're watching the debates just as closely as you are, and we're really trying to figure out the best way to make sure that our folks are served, and we're happy to work with the committee if there's other ideas that come down the pike here.
Thank you, Mr. Chairman. Matt, you said premium reduction. That's very nice. There's two very nice words. However, is it full disclosure then to the employer that, as an example, over the last 12 months, the rebates to your plan, assuming 1,000 employees covered without counting dependents, the premium, the rebates were $750,000, and we are reducing your next year's premium by $750,000. Do you fully disclose that to the customer, or do you sort of promise we're doing it internally?
Mr. Chair, Representative Casper, we have a pretty transparent discussion with our members.
Thank you.
Senator Dever.
Thank you, Mr. Chairman. Matt, I'm not clear on the differences between an ACO and an MCO. Can you help me out?
An ACO is basically an accountant, Mr. Chair, Senator Dever, an ACO is essentially a narrow network plan. It's basically an insurance product where the patient is really where the payer has basically partnered with one health system. And so you're going to that one health system for the vast majority of your care. Whereas an MCO is actually a managed care organization. That's basically a business structure that's an insurer that basically assumes a lot of the risk for the patient's care.
So in an ACO, it's not that the provider organization is working closely with the patient in their care as in a managed care organization.
No, they are. With an ACO, basically, the provider's taking on some risk, and we're taking some risk as well as we're managing that patient's care. And the provider's working with the patient, and it's within parameters they've worked with, and we're working to pay those bills.
With an MCO, we've got most of the risk with managing that relationship. So it's more of a partnership with providers when you look at ACO.
Further questions? Thank you very much, and thanks for being politically correct. Representative LaForte, sorry.
Thank you, Chairman Kaiser. Thank you for those suggestions. You heard the chairman say at the beginning of the meeting that we're going to have $800 million to $1 billion in the next 10 years. So we're going to have to be bold. And some of the things you said were of great interest to me. And we've actually had PBM lobbyists testify in front of other committees that I've on that said that we exist to lower drug costs. My question is, did that just come out of your mouth? You know, for me, there's going to have a great deal of transparency. So I would ask you or any of your panel members here to please give us some ideas, give us some thoughts on how we can address this, because baby steps won't carry the day. And it's tremendously frustrating to us, many of us that sit here and be told things that we know just simply are not true. And that's because of a lack of transparency. You know, we talk about specialty drugs and all these other kinds of things that are, and we got to remember PBMs, if I remember correctly, started as claims processors. I would very much like for them to go back to that business. But so at the end of the day, we have to be bold here, and any ideas or thoughts that you would have, don't have to answer it now, would be greatly appreciated. Thank you.
Mr. Chair, Representative LaForte, I do have one legislative proposal that's been moving through a couple states that would encourage the committee consider, and that's drug transparency legislation. There's been laws that passed in California, Oregon, one in Nevada that's specific to insulin, and then I believe Texas just passed a new one. I have not had a chance to read that law, but my understanding is it's very similar to what we saw California and Nevada pass. And essentially what that requires is for manufacturers to publicly disclose any increases they're making in the wholesale acquisition cost for a period of time in advance. And in terms of implementation, what we've seen with the states that have passed that is we've seen manufacturers back off some increases, and we've also seen some instances where we've seen folks give a little rationale. Hey, I'm doing a 17% increase on your glaucoma med because I know my friend up the street is going to do the same thing. And so that's one that I would say, I don't know, it's probably a toddler step, but it's given us a sense of what's going on when it comes to just the price setting itself, and that's something that we still don't have.
Mr. Chairman, continue. Thank you, Mr. Chairman. Thank you. So I guess I would ask any information like that. You have other potential laws from other states or what have you. Specific information would be, again, greatly appreciated because we need to move on this.
I'll be happy to follow up with the committee.
Committee members, I will, during my opening comments, I said I had a drug transparency bill being drafted. It's after the Texas model, and you will have it before the next meeting. Who's next?
I think we'll use this chance to kind of tie with what Matt was talking about with pharmaceutical pricing. I like to use this analogy when it comes to prescription drug pricing. Health plans have to prove their premiums to their state regulators every year, but pharmaceuticals never have to prove their pricing to anyone. And I think that's the most telling thing when it comes to pharmaceutical companies. We've seen not only price increases on specialty meds, on new medications, we've seen them in generics. We've seen them in prescriptions that are 15, 20 years old, where for sure the pharmaceutical company has already made back the cost of research, development, marketing, all in the matter of getting money. We've been really lucky in that our state next door, Attorney General Ellison, has decided to go after that. He discovered that there was proof of collusion amongst the generic manufacturers at a conference last year in St. Paul to do price fixing, and he's decided to go after them. We would greatly appreciate any other Attorney General going after them for price fixing, for collusion among them, anything to control the pricing.
Mr. Chairman, to pivot a little bit and talk about some of the ways United is using technology to help both providers and patients navigate this very complex and costly system. When we talk to our members, it won't surprise you, cost is the number one consideration they have. But then immediately following after that is the complexity of navigating the system. And especially among the core people that Matt talked about, who are chronic conditions, comorbidity, or have other complex cases. It is both a initiative on our part to drive both for economic and also for mission-driven reasons, a experience for those people in particular to navigate the system in a much more coherent way. So one of the things we've been implementing, particularly in this region, is to hire care coordinators that are focused on special needs kids in particular. Kids who are going to go to weekly, not monthly, not yearly, physician visits, scheduling those visits, including coordination with any public programs that they might be eligible for. Because those kids tend to be not only covered by private insurance, but by Medicare or Medicaid. So how do we knit together all the funding sources and provide them a seamless customer experience? So we do that kind of work. On the provider side, you talked about, or I can't remember which of the representative senators asked the question, how do providers know about different drugs choices and what impact, financial impact, they might have on their member, the patient in front of them? One of the things we're rolling out right now is a pre-check by script app or utility in a provider's office, so that when you're in there literally having your conversation with your provider, you can put in the prescription and then it will say, by the way, X, Y, and Z are going to be cheaper. And then the provider still makes the clinical decision, but now informed with that data point that they didn't have access to before. I think we recognize and fully believe that providers are aligned with trying to understand and work on reducing the cost of the care that their patients access and that employers pay for, that states pay for. I think a lot of that has to do with the data we provide them, and also to give them sort of information to align their incentives with patient care. We look forward to helping inform North Dakota as it works on probably the toughest, easiest problem in the world. I say the toughest, easiest problem because healthcare is expensive because healthcare is expensive. The problem is how the heck do you figure out how to deal with every one of those dilemmas. Every time we in the insurance industry work on something that is about reduction of care, someone will, perhaps credibly so, claim that it impairs their access to care, or it has impact on local communities, or it has impact on a standard of practice. These are not easy questions, but we look forward to working with the committee to help talk about and address them.
Thank you, Manny. Senator Roy.
Thank you, Mr. Chair. And Manny, oh man, I lost it already. Shoot. What did you say? Oh, I wish I'd written that down because I think it was a really good question. I'm going to come back to it in a second.
Any further questions? You know, panel, I would just like to throw out another concern that I have, and it's clear we can identify PBMs and some of the abuses that have occurred, and that's low-hanging fruit almost for some of us. But on the provider side, I have an associate that was on an airplane going to Chicago to a meeting, and midair something went terribly wrong with one of his eyes. He landed at the airport at O'Hare, called his ophthalmologist here. The ophthalmologist, he described what happened. The ophthalmologist said, go immediately. I've got a classmate down there who is a surgeon. He can take care of you, but don't even get your bag. Get in the cab and go there, which he did. He went there. He went under immediate surgery for 2 hours. The bill was $200,000, and it was paid by Blue Cross Blue Shield. I have to say that that's a little bit unrealistic. And yet we don't hear that coming from you. We asked when we met with your folks, we said in terms of patterns of care, some of the things that are happening don't seem reasonable. And yet I'm not qualified, nor do I want the responsibility to make those decisions. But my physician happens to have practiced in a small rural area for 17 years. And then he moved up to the big metropolis of Bismarck. I have a very light complexion. I've been in the sun way too much. In my youth, I'm better now, but still not perfect. But I have, on occasion, a precancerous cell growth. He looks at it and says, that's precancerous cell growth. Goes down the hall, gets liquid nitrogen, and comes back and zaps it. Now, that's one-stop shopping. I paid one copay. He charged me a little bit more because I had an office visit, and he charged me for a procedure. But many of our docs will refer that to a dermatologist, and now you wait 8 to 9 months. And you have a fee that's much higher. We have things going on the provider side that we're not talking about. You're not talking about. It's easy to talk about the drugs, but what are we going to do to address? I told people before this started, as we were just chatting, we're going to have some frank discussions on this committee. And this is one that concerns me. And yet we're never talking about it in these meetings. Comment.
Chairman Kaiser and members of the committee, I think you're kind of hitting at one of the foundational reasons that I came to Blue Cross. I was on the public health side and on the hospital side before that. I think fundamentally the way that we fund healthcare is wrong. We're paying, in a fee-for-service world, you're paying to do more, which creates crazy incentives to do more and more and more of those things. So Manny mentioned really trying to shift to a different way to pay for things. So outcome-based payment. So that's part of what we're trying to do to address the issue. So how do we create those incentives for providers to do the type of things like you described, take care of it right there in the office, you're not being referred on to 5 different specialists to take care of your one issue. Part of that is data, making sure that they have the information that they need to properly care for those patients. And that is something that we do provide as an insurer because they don't necessarily know that that individual has been to 5 other providers. So it's upon us to make sure they have the information to look at that and understand that they had an MRI over here and a CT over here and help them in the coordination of that care because it's extremely difficult in the provider world when you have varying EMRs. So some people have Epic, other people have Cerner. They don't always talk to one another. So what do we do to help them bridge that gap? And that's part of what we're trying to do with value-based programs. So if I can continue.
Sure.
Okay. You all should have one of our Blue Alliance reports. So this is a value-based program that we just finished up the first 3 years. We're going to launch another 3-year program here in January. Prior to doing Blue Alliance, we did a total cost of care arrangement. We've done Medicare Home. We've done a variety of value-based programs, all trying to get at that question. How do we align incentives so that doctors can be doctors and deliver the care that they want to instead of running on the hamster wheel? So when we look through the report, you can see that we have a lot of providers participating in this arrangement. So that didn't always used to be the case. We have a lot of providers that are coming to the table having this very same conversation. How do we do what's best for the patient and provide the incentives for you to do that? Because if you think about it in a fee-for-service world, why on earth are they going to keep people out of the hospital or keep people out of the ER? That's how they make money. We see hospitals close if you don't have enough people to fill the beds. So how do we align the incentives differently? So I'm very encouraged by all of these providers coming to the table to have that conversation with us. And we have been talking about it for 3 years. So the rest of the report kind of goes through some of the things that we've seen as part of those conversations and the partnerships that we've had. So 42 different organizations really participating at different levels. Some of them are in a base arrangement. They're not able to take risk or not ready to take risk.
have quite a few level 2 and level 3 organizations, which means that they're either sharing in the savings or sharing in risk as well. So lots of progression as we've moved on through the 3 years of the program, and we will continue on as well. So a lot of different quality measures. Some of the typical things that you would see, clinical, breast cancer screenings, child visits, things of that nature. Based on the discussion today, I'm going to concentrate a little bit on the cost and efficiency measures that we have. You had mentioned in your opening comments, Chairman Kaiser, about the ER experience. And seeing a lot of folks that are going into the ER for things that probably could be handled in a different setting. We saw the same thing. We decided that we wanted to look at it as part of this program. So 3 years when we introduced the program, we went to what we call our clinical quality committee, so physicians across the state. We said, hey, how about we look at ER visits? And that was a very interesting discussion. I think we all realized that we play a part in this and helping to reduce ER utilization and directing people to more appropriate levels of care. It was tough, though. We hadn't focused on that historically. We've been looking at those clinical measures. So we all agreed that let's do it. Let's see if we can make an impact here, and we certainly have. And that is on page 9 of that report. So potentially preventable ED visits as well as potentially preventable hospital admissions. So meaning that they're going to the ER or the hospital, but potentially it could have been handled in different settings. So not a guarantee that some other intervention would have prevented that ER visit, but likely. So a lot of great progress has been made across the state. We will continue on with those 2 measures because we still think that there's room for improvement. One of the encouraging things is one of our vendors has a national benchmark. They work with a lot of plans across the country, Medicaid, Medicare Advantage, as well as commercial. And the national trend they've been seeing an increase in ER visits. In a lot of other states, they have pop-up ERs, freestanding ERs. The general public has no idea it's even an ER. Well, what do you think that does to the cost of healthcare? People are using them thinking they're just going to an urgent care clinic, and they're getting a huge bill from that. So luckily, we haven't had that here in this state. So I'm really encouraged by the fact that our potentially preventable ER visits is going down while the nation appears to be going the opposite direction. So that is encouraging news. I think the other piece that we've seen with regards to shared savings is the Blue Alliance program is we have experienced shared savings. So we are making an impact with the data that we're providing the providers in trying to align those incentives. The hard part is moving away from a fee-for-service world, because every provider is at different stages of their journey towards a value-based program. We have providers that are very on board, that are doing programs with CMS, so with their Medicare populations, and other commercial payers that are here with me at the table. And we have some providers that are not as willing to do those arrangements. So, and all the arrangements look a little bit different as well. We're all trying to get at the foundational piece of aligning incentives, but we take a different approach. For us, well-child visits was a measure that we landed on because our well-child visit rates are really, really low. Medicare doesn't care about well-child visits because that's not their population. So just like Stanford Health Plan or United might pick other measures because that makes sense for their population is what their data is showing. So we try and pick things to measure the providers on where we see opportunity for improvement and continue the dialogue with them, because by no means was this first version of Blue Alliance a slam dunk. We learned a lot of things from that, and as we always do when we do try to do any type of value-based program, and we work with our physicians and the health systems across the state to make it better next time. And so that's kind of what we're in the process of doing. But to your question about having the conversation, I think we have the conversation all the time with the providers, is just trying to find the right mix that everybody can agree on, we can move forward.
Any questions for Chelsea?
I did budget.
Senator Lee.
Chairman, this isn't a question for Kelsey, but a follow-up on your previous discussion, 1 through 7. So I wanted to, I'll ask it when it's appropriate.
Okay. Senator Royce.
Okay, so I did come up with my previous question, but I also have a question that might be to everyone, including to Commissioner Godfrey. Just as we're looking at the cost of healthcare in general, having worked bedside and worked now in administration for enough years, feels like every time there's a new program, every time there's a new piece of regulation, you may decrease the cost through having that higher quality, but you sometimes increase that administrative cost at the same time. And so one of the challenges, I think, as you're collecting the data from the providers and as you guys are working on programs is how do you create a program that really does get at that quality outcome without penalizing people for patient and non-compliance. That's always another challenge is as a healthcare provider, I can lead the horse to water, but I can't make them drink. And so you want to incentivize the right behavior both for the provider and for the patient. But to track those things, you now have to add another administrative person to track the data. I mean, I spend 50% of my time in Excel spreadsheets. You don't need a nursing degree to do that, right? But you need the nursing degree to be able to think through why is this and that piece of it. So just a challenge to you as you're thinking through all of these things is what are you adding to the pile as you're trying to subtract? And then the question that I had for you is when you were talking about that prescription drug technology, and then you talked about the different EMRs, how do we make it so that we're not requiring providers to go to 3 systems to be able to write one prescription and get some of those things integrated into those EMRs so that our providers can sit down, do their work, and move on to the next patient rather than spending so much time babysitting the chart?
Mr. Chair, Senator, so let me introduce you to my friends at my sister company, Optum. That's their sweet spot. They love to play with technology and toys and pulling together data. But I think you have identified one of the biggest challenges to helping inform practitioners, payers, patients, is access to data that's actionable and intelligible, right? And it's siloed and it's fragmented and it's not particularly coherent. That is what all of us are trying to work for. I think there are incentives that are sometimes contrary to be able to uniformly pull that together. But having said that, I think what you've articulated is something we observe all the time. When we implement a wellness initiative, when we implement a quality initiative, when we implement any initiative that sort of impacts providers, payers, members, one of the biggest questions we ask is, beyond the value it will provide us, is it an administrative PITA to implement, right? Will it actually generate more friction, cost, noise that's not worth the $500 we're going to save or whatever? And so one of the biggest conversations we have all the time is scale is great and cool, but how do we articulate that the implementation process to get there just isn't worth it? Which means there are a lot of cool things we pilot once and go, this is just not scalable. And we have to sort of iterate that decision making all the time. Now, one of the things that we're also working on is how do you leverage technology to make things iterable and replicable and sustainable in the long run. So we talk about site of care and we talk about access to Chair Kaiser. Could your provider FaceTime you, look at your particular precancerous growth and make a determination based on, I think we're getting there. But then when the health department talks about the social determinants of health, one of the things I would ask is, does every community in North Dakota have access to broadband, right? If you're going to do telemedicine, you probably need some really robust pipes backstopping those providers as they look at smartphones, right? If you're having a virtual visit with a therapist, for example, if that's a way to provide access, and that call is buffering, I would imagine the therapy session might be suboptimal. So to answer your question, yeah, one of the things that we talk about all the time is when we bring together data and we try to implement those, how do we do it in a way that leverages existing infrastructure and minimizes the need to sort of tear things up and build new stuff? Not to say you don't have to do that once in a while, but we really, really like steering the current.
Any other, Senator Madden?
Thank you, Mr. Chairman. And members of the panel, it seems like you each do some positive things to try to impact cost and quality care. And I'm wondering, in light of an earlier comment, that we in North Dakota are kind of like a, part of just the city someplace else. I mean, we have a pretty small population. Can we afford all the infrastructure that we have in our insurance companies? I mean, like, if you all were sort of implementing your great ideas at the same time, it seems like we'd get a lot of benefit out of that. And I'm just wondering sometimes if that's the struggle we have in North Dakota, where the small population makes for a greater requirement to cooperate in order to get the benefit. And I just wonder if anybody want to comment on that.
Sure. Chairman Kaiser and Senator Mather, and I think that's one of the reasons that the Cross Michigan North Dakota made an agreement with CMS to join the Comprehensive Primary Plus initiative. So really what we did is commit to Medicare to align, at least where it makes sense, our population with their program. So there's providers around the state that have engaged with Medicare around this particular program that aligns incentives for primary care. And so we've made an effort to align with Medicare and partner with them because that creates scale. So that's one strategy that we have deployed, if you will, to try and help providers and trying to create that alignment overall.
I have something to add to that. I do think, Senator, one thing to keep in mind, though, there are some things that North Dakota is doing well, and you're taking a more thoughtful approach and that we would actually like to see in other parts of the country. And one example of that is really how you deal with proposed benefit mandates. Look, as policymakers, you've been put in awkward positions. You have a patient with a child or a family member who a certain treatment or therapy is working to cure their ailment, or it's alleviating their pain in a way. But our evidence and our data says, okay, that worked for your family member. We don't have enough evidence to say that that works for us. And that's before we even get into cost. You do have a mechanism for going in and piloting that out and taking a look at the cost piece. I would say that that's something you do well, and you should look at ways to improve upon that, because that's something that we see in other parts of the country is becoming incredibly problematic, and it is going to raise prices. And it's going to alleviate efforts that other states are, other states are in the same position as you. They're passing reinsurance laws, and even if you do get some relief from that, well, that's great. You ate all that up with the 5 mandates you just passed. That's one thing you're doing right. And another piece I do want to emphasize is the reinsurance law that you did pass is going to have a meaningful input effect. We look next door in Minnesota, speaking for Medica, we were able to provide 17% of premium relief in 2018, which translated into an average of between 12 and 24% reductions in different products we offered around the state. One of our competitors had 26% average premium relief. Now, I can't say that's going to be what happens here, or I don't know. I mean, that's where we're in the middle of a period where we don't know. But what I can tell you is these are meaningful steps that you've taken to really take on the rising cost of care, and I know there's still work we have to do.
I have to tell you that I agree with what you said, and that provision that we run it through PERS for 2 years and test every mandate has been circumvented in every mandate for the last about 3 or 4 years, because they put in the legislation you don't have to do this. So although we had the right idea, our bill sponsors seem to think that their idea is so much better that we don't need to do that. So it isn't really functioning the way it was designed to function.
Well, Mr. Chair, that's an example of rising costs that are probably unnecessary. There might be unintended consequences.
Other questions or comments? Committee members, I would love to form a partnership between the providers, the insurance companies, the legislature, and fight the fight. And that's relative to EMTALA. Many years ago, I was on the Med Center board, which is now Sanford here. We, as Senator Lee stated earlier, when you present in an emergency room, and by present, the law says anywhere on the footprint of the hospital. It isn't in the emergency room. If you're on the sidewalk and you have an emergent case, you're in their emergency room. I don't know if you realize that or not, but we did what we thought was such a smart thing. We put the walk-in clinic about 50 yards down the hall from the emergency room. And within a very short order, we were cited with 2 EMTALA violations. And I can tell you as a result of that, even though as Senator Lee said, all you have to do is evaluate, that's not what happens in emergency rooms in the state. They have to do the evaluation, they might as well do the treatment and charge us that much money. But doesn't it make sense to have our walk-in clinics have to be, I don't know how many thousands of feet away, but in the middle of winter, you're in the emergency room and they tell you you're bleeding or whatever, but it's not life-threatening. It takes a few stitches and they say, well, drive the 4 blocks down to the walk-in clinic and it's 10 below outside. You're gonna say, just stitch me up right now. Here. It's a fight. I don't know what agency oversees EMTALA, but North Dakota should be going to that agency with a waiver saying, let us do a pilot project. Let us see what impact we could have on emergency room treatment by being able to send them down the hallway in the same facility. It was amazing how well it worked until we had the 2 citations. And I'll tell you what, you get 3 and you might be out of business as a hospital. So it's nothing, we instantly shut it down. And it made no sense. I would love to see us fight that fight. Senator Lee.
I couldn't agree more, and we could go on more time than we have this afternoon with some of that foolishness, but it's also equally stupid that a senior care facility cannot transfer. Now, and I'm not talking about the moratorium, never mind that part, but that they can't look at even transferring from skilled care to basic care or assisted living kinds of beds. Because if in a small facility, if there's somebody who calls in the basic care side, because that's Medicaid reimbursable for those of you who don't know North Dakota's the only one who has that, then the skilled care facility is considered to be unattended, even though it's across the hall from the desk. So some of the small communities facilities who would really benefit from having mixed-use buildings can't do it. It is bizarrely stupid. And if I may go on to follow up on your original comment about your dermatologist, some of us make regular visits there, and I would be one of those. So within the last, I don't know, 6 weeks, I was in once. I had 4 procedures, 3 of them very small, 1 slightly larger, but like the freezing and that kind of stuff. Because there was more than 1 procedure done in 1 visit, I got discounts on the reimbursements for all of them. 50% reduction in reimbursement from PERS on 1 and 25% on 3 of them. So what my bill was for that 1 office call with 4 reasonably small, very small procedures done was well over $600. Now, that is not the insurance companies. That is because the provider has said, we don't have to process every appointment, so we're going to, it's all in one. But that's a savings to them and a time savings as well as money savings to me. Don't charge me, please, although they're doing it. And discount my reimbursement or the doc's reimbursement, and my cost. Because she did more than 1 thing at one time. Isn't that an efficient, cost-effective way to do something? I ask rhetorically, because it's not happening. So there are lots of us with our fingers in the pie, whether we're providers or insurers or patients who have something to do with this, and we I mean, that blew me away because I don't know if there's a change in the rules or whatever, but I've never had that happen. I thought it was wrong. I'd rather buy an airline.
All right, any other comments by panelists or committee members? You guys shined today. You were great. Thank you very much. We appreciate you sharing this information, and we look forward to seeing and hearing from you in all of our future meetings. So thank you very much.
Thank you, Mr. Chairman.
Committee members, I can assure you that the next segments are not going to take that long. So why don't we take a 10-minute break and be back here. Let's be back here at 3:45, and we will start right at 3:45.
Yeah, it gets a little long.
No. I wish that was true.
Hey, Ryan. Ryan, it's Marvin. It'll have to be a little longer than that. I'm in a meeting. I can call you back. I think we'll be done about an hour, so I could call you back when I get done with that. Okay. Yeah, I'll have lots of time, after the meeting's over, and I think we'll be done about 4:30. So I can call you then. Okay. Talk to you later. Okay. I really wish the robocall people wouldn't call during legislative meetings. Yeah, we got education fixed. I just wish on the clinics the reimbursement rate was a little bit higher the closer the time to call and get in. Like I don't think if I call now and I can't get in for 3 weeks, I don't think I should be paid as much as I'm calling now and get in. Because what that does is it encourages using the emergency room if I can't get in the clinic. We don't have walk-ins. You have walk-ins. I don't have walk-ins. All I have to do is drive 120 miles to the closest walk-in. And again, I think I should be able to walk into my clinic on the day I call. And our clinics in this nation, the truth of practice, and the doctors love it once they do it. But I think it's a lot like the pharmacists where they couldn't dump the 30 pills out for at least an hour just to show that they were power. And I think the same way the clinics, you know, and the clinics, if they do a little bit of care scheduling, like you shouldn't do the, oh, this is your routine visit Monday. Those shouldn't be on Monday because there's a backlog. Yeah. But they have to do some management. But there are clinics that do, you call today, you get in today. And once they do it, it's the same amount of work anyway. Once they actually chew through and get to that, the people in the clinic actually love it. Try to force them to get to it. But a little bit of an extra payment, it's amazing what things happen in healthcare for a little bit of extra payment. But I suppose that would require 3 more people in the billing department to argue about what they would call them. Soon they'll just follow my chip and they'll know when I call. And so that's the problem. You want a good doctor, but if you're a good doctor, they get you patient.
That's part of it. You gotta go to work. I do. That's not fair.
Oh no, that's not it.
Oh, this is fair. This is like, it's got broccoli.
Those big chunks of salt don't actually count as salt. The digestive system does get faster.
First thing my bubble.
I end up sometimes driving through eating sunflower seeds or something like that to fall asleep driving into the stomach. You know, there's a trade-off. I like the sunflower seeds, but I ate too many of them, then my gout shows up. I stay away from them. That's better off eating cherries.
I definitely have
When I figured out the energy drinks like pardon, no, don't drink an energy drink unless you have an extremely slowly you don't want to lose your pictures and so on. You still have your emails and all those. That's a lot makes sense. But personal stuff, you got to. And unfortunately, I did that. I did that. Oh, just subscribe for a little monthly fee. Wow. I just need so I was worried about my quota. Each time we got so much. Some good water. How's your summer going? I will. Oh my. Yeah.
Do you think that we
So are you aware, how much does money hit you on the bill?
Well,
They didn't want to give it to me. Because I have water's not my said I needed a certificate of elevation. I bought them from the all the way.
Just standing there with the GPS and not going more.
I invited him out. I'm like, come out. I'll have you walk with me up the hill where I'm gonna build the garage. Stupid farms. And they finally realized it. I think they realized it. You know, the county, state, FEMA, all of them. But they want this. I call it. So go back to the county and say, we can have a stricter requirement. Plus, you didn't ask for the state. You don't have to. You don't need one. So I'm back to the state. We can have a stricter requirement. I just kept inundating them with emails and phone calls. Here's the requirement. People don't true scale. That's it. Okay, I can do it. I don't know why that
Love that sound. I understand the concerns. We've been through this, everybody, but we have very precise elevation data for your students go right there, and this is the accurate perception. All right there. Why would the city of
That's why
Thank you.
You're really putting the hamster. I remember down in Fargo, they were spending a lot of time getting everything out of the floodplain, cleared out of the floodplain. And there was a friend of mine who said, oh, it's the house on guard, it's not the floodplain. You know, I'm heard the alternative here, but you know, like this, like, oh, well, they got it because it's not floodplain. So it's not floodplain.
We ask the legislators to take their seats. All right, committee members. We'll move to the next item on our agenda, which is a presentation by Jennifer on a background memorandum on healthcare delivery study. Jennifer?
Okay, thank you, Mr. Chairman, committee members. If you've kept your material in order, your next one should be healthcare delivery study background memorandum. And I'm not going to read it to you, but you'll notice that it's got two large attachments. One of them is an NCSL document updated in 2016, Improving Rural Health State Policy Options. The other one is the document put together in 2019 by the School of Medicine and Health Sciences Advisory Council, Health Issues for the State of North Dakota. I'm going to refer to both of those documents as I go through this background memorandum. For starters, just what your study is we've got a directive to study the delivery of healthcare in the state. The study must review the needs and future challenges of the North Dakota healthcare delivery system, including rural access to primary care, the use of emergency medical services, strategies to better serve residents, and the role of healthcare services in the future development of the state. So we're going to master all that by the end of the interim, and we'll have all the answers. It is pretty broad. As your background material shows, during the previous 4 interims, we have had broad studies on the healthcare delivery system, although they typically have included consideration of the ACA. This study does not preclude consideration of the ACA, but it does not specifically mention the ACA. So it'll be up to you whether you want to get status reports on the ACA, as we've done in the past. So the background information on those previous studies is on page 1 and the first half of page 2. And then the memorandum goes into the recognition that North Dakota is a rural state. I got some statistics on there showing you how rural it is, but we all live here, so we know. Rural healthcare delivery is nothing unique. Other states are looking at it. That's what makes that NCSL document so helpful, is other states are looking at it. And I've summarized some of the strategies and options that NCSL has included in their report. I'm not going to go over them because you've got that NCSL report attached to your background memorandum. So other states are looking at it, but North Dakota is looking at it also. We've got that document, that 2019 document the School of Medicine and Health Sciences put together. And the appendix right before that School of Medicine document is the duties of the advisory council. I would encourage you in your free time to look over what they're required to do. That report that we've attached here comes to legislative management every 2 years. This interim, it is scheduled to go to a committee that is not ours, but they will be presenting it. There's no reason that we can't ask them to present it to our committee as well, because it really is well suited to this study of the healthcare delivery system in the state. We've got a study approach that's included here. The committee may benefit from receiving information at the state level regarding identified strengths and weaknesses in our healthcare delivery system and recommendations. I know we might also request presentation of the recent, current, and upcoming biannual reports of the School of Medicine. So we've got our 2019, we've got our past. We'll have one that's coming up this biennium, and then what they're looking at doing in the future. I think that would be really helpful. The School of Medicine has always been really supportive of what this committee has done. And in addition to looking at our School of Medicine and what their report is, it might be helpful to look at that NCSL document and what other states are doing. We don't have to recreate the wheel. They may have something that spurs our imagination. And that is what I have for background on that study.
Any questions for Jennifer? Senator Dever.
Mr. Chairman, I don't necessarily have a question for Jennifer, but this study was put into the Human Services Budget Bill by the Senate Appropriations, and the conversation that we had in there might be useful to this. I think we've talked about most of what we've thought about already in this meeting, but I think there were a couple of things that might be useful. You know, in 2017, we decided, and this was primarily regarding Medicaid expansion. In 2017, we decided to reimburse at commercial rates. I think for 2 reasons. The first reason was 10% of state money will get you 90% better money. The other thing that was going through my mind that I think was wrong thinking at that time is that this is a way to push money out to the critical access hospitals to keep them viable. And the reason I think it's wrong thinking, during the last interim in predecessor to this committee, the Healthcare Reform Committee, one of the administrators of large hospitals said that 90% of healthcare in North Dakota is provided in the 6 largest hospitals. So it's not going out to those critical access hospitals anyway. So I thought, rather than sending money out to the hospitals, how about we provide for services that they should be in a better position to provide more of? And how can we do that? Utilizing telehealth, telebehavioral health, telemedicine, whatever. You know, do they need to go to the big city once a week to see a specialist when their primary care doctor could probably see them and consult with their specialist. And I think, I could envision utilizing those resources. That a lot of those people that leave those small communities to go to the big city could stay home more often to do that. So the critical access hospital, I'm not sure exactly how many there are, is it 33, 35, something like that? 36. Some of those are associated with nursing homes, some with swing beds, some with clinics, some are associated with or owned by the large hospitals. I don't know that we have a real good inventory of what that looks like. And I think all of that also recognizing that those those hospitals are not owned by the state. They're in charge of their own future. But how we reimburse for services that are provided for those is a responsibility of the state. So I think that makes this study pertinent, but I think should also then include hospital association and all those various. And also, we've done studies of emergency services, trauma care, those kinds of things, and we've done some really good things. But how does all that fit together? We talked about air ambulance earlier. And it was interesting to me, I asked a question one time, and Representative Todd Porter was in the hearing. If somebody in Elgin has a heart attack, or in Flasher has a heart attack, do they go west to Elgin to find out that they need to go east to Bismarck? And now they have the ability to diagnose and all that kind of thing. And Representative Porter said that they would send an ambulance out to meet, and you're in the back of an ambulance like that with the communications equipment and all the medical supplies and everything, and the expertise that's there. It's almost like being in an emergency room. So that care has improved a lot. It was probably a dozen years ago that we started that trauma study. And I asked the question, if I want to drive from Bismarck to Pembina from a trauma care point of view, should I take the interstate? And the answer was yes. And then it was in 13 or 15 when I asked the question again, and they said, no, we got pretty good care in those critical access hospitals across the state. So we do have that care, but they're struggling to stay alive. But how could we create a vision that would make them more viable from the services that they provide, and not just sending dollars to them?
Senator Hogan.
Thank you, Chairman Kaiser. I'm really excited about this study because I think it's critical. I think there are two ideas that I'd like to at least, and I don't think we need to change the study language, but put on the table. One is the whole role of federally qualified health centers, because they've been very effective, both urban and rural. And I think sometimes if we could expand the FQCHs, that's a tool that I think we should really look at. And the second issue I'd really like to consider is the interface between primary care and behavioral health. We heard from the providers how they're really doing that. And in our rural communities, I think that's something we should also, because sometimes we have them in silos. Primary health care is here and behavioral health care is here. And the more we bring them together, I think the more seamless and the more responsive we are to citizens. So those are the two things that I think we should look at.
Senator Lee.
Mr. Chairman, thank you, and I absolutely support what the previous two speakers have talked about. I think this is quietly probably the most important study in the interim of the whole lot. I mean, this is a really big deal. Just a little clarification on the critical access hospitals. There are 36. 4 are in the 4 medium-sized cities. The other 32 are in the smaller communities, and of them, the average daily census is 4. Yeah, is 4. And for 4 of them, it is 0 to 1, the average daily census. We cannot afford to provide traditional hospital care when there might not be any patients in the hospital until I show up there. Now, that doesn't mean I want the critical access hospitals to close, heaven knows. So I think to tie in also with some of what has already been discussed, with 2124, which redid the social services delivery system, So that ultimately the goal is to have comparable services provided to everybody, but just not necessarily in the same way. We need to see that, because that is a remarkable thing that we just passed in this last session. And the zones are all established, you might all like to know that. And it's moving forward, and it's a big deal. But we need to look at doing something comparable that enables all of those providers to be doing that work in those areas, perhaps with a little different job description in some cases. But there are some exciting examples of technology that have been mentioned briefly here today too, that would enable people to sit at their kitchen table and have their appointment. And so I think this is going to be an interesting study. And I don't want anybody to think that the goal is to close critical access hospitals and that's what we're doing it for. It's to figure out how we can make it work. What do we do? And we probably will need to enhance some emergency services, so I'm glad to see you have them on the list. It's complicated and we probably won't have it perfect by the end of the year, but I am excited to look into this, so thank you for having it in your committee.
Senator Roy?
Nope, I was
You're
pointing
good?
to her.
Oh, all right. Anyone else? All right, then. Let's see. The next study is on guaranteed issue.
All right. So the next memo I have, Mr. Chairman, committee members, health insurance guaranteed issue background memorandum. And I gotta admit, I have a lot of fun writing this. You've got colored graphs. I'm all about this. So Section 17 of Senate Bill 2010 directs the study of the feasibility and desirability of state guaranteed issue provision for health insurance. The study must include consideration of protections for individuals with pre-existing conditions and consideration of whether to restructure CHANT. Those are at least two different issues. There are at least two different issues there. It's interesting the evolution of this study. Senate Bill 2010 was amended by the House to create a new section of North Dakota law that said, notwithstanding any law to the contrary, an accidental health insurance policy issue under this chapter may not take into account any pre-existing condition of an insured or applicant, including waiting periods, refusal of coverage, and rate setting. It's a pretty broad statement. There was some testimony after that was added to the bill that it may have been more far-reaching than was intended. And this study section was added in replacement in conference committee. So I think generally what this study came about was if the ACA goes away and we no longer have guaranteed issues, so they can no longer take into account your pre-existing conditions, we want to change our state law so that we limit or prohibit consideration of pre-existing conditions as relates to being accepted for your policy or having your rate set for your policy. So having said that, this memorandum goes into some neat stuff on medical underwriting and which policies can consider medical underwriting, which ones can't, what the history of the ACA is, goes into until the ACA's provision in 2014 said you couldn't take into account pre-existing conditions. The ACA had a temporary high-risk pool that operated in this state. It operated parallel to our CHAN program, which also is our existing high-risk pool. That federal one was temporary, it went away. Our state CHAN program continues. It just has dwindling numbers as fewer and fewer people qualify for that, given the ACA's prohibition on taking into account pre-existing conditions. So there's some interesting data here on the individual marketplace and who this applies to. It's typically your individual market, and there's some really neat data on churn and how many people are high risk at any given time, how many people fall in and out of that. I really enjoyed that. Having said that, the other piece of this study is looking at CHAN and whether it should, I suppose, whether it can be utilized as a safety net if the ACA goes away and we want to have a safety net at our state level. So that's background on this, and I'm happy to answer any questions.
Representative Casper.
Thank you, Mr. Chairman. I was looking around the room to see if any of the folks were left that presented. I don't think they are. We really wanted to talk to an actuary, but one of the maybe they're in the back, but I don't want to put them on the spot after I thought about it. But one of the questions that might be interesting to ask, maybe by a letter from you, Mr. Chairman, is what is the cost to an overall health plan, like in a state, on pricing for premiums to cover pre-existing conditions on the insurance premium? I've been told a number of years ago that was really only about 1.5% increase in everybody's premium. It would be interesting to ask our insurance companies, and if you could keep their names confidential but just give a range, I'd like to know what because they're pricing for it in their premiums. And it would be interesting because I really don't think that a pre-existing condition coverage is a really big cost, because most people have coverage and they're already covered for pre-existing conditions where they're at. So it'd be interesting if that would be something you might consider.
Okay. Any further comments or questions? You know, committee, I will share with you, I'm outspoken on the pre-existing condition part. As many of you know, my wife is the executive director of our Ronald McDonald House. And prior to the ACA, what we observed were medical bankruptcies for very young families. And they were, it was so sad to watch. It does not take long to get to $1 million with a baby. And those are the kinds of parents we have at that house. And they, you know, you're going to do anything for your child. And that means liquidate every asset you have if necessary. And then the alternative is medical bankruptcy. And at which point, who wins? They go on Medicaid. They lose every sense of pride they had in the family. Frequently divorces. This is so much bigger than simply pre-existing conditions. And I will speak without reservation that the cost to society and to the state is so much greater by not covering pre-existing than dealing with it directly. It just, this is not rocket science, but I may be biased.
Mr. Chairman.
Representative Nelson.
Yeah, on pre-existing, you know, what we had before was we had people were locked in to a certain policy or a certain job or whatever, and they couldn't move. They weren't free to move, and often this hurt their family income. And then the other thing that happens, you know, is we talked a little bit already about the cost of the bureaucracy. And okay, these people go into this high-risk pool. Well, the system's going to cover the same cost anyway. You know, it might be more. It's just now we created another program and another bureaucracy and another argument with insurance companies and stuff. And I think it costs more to have that separate pool than it's worth. So that's my comments on that.
Any other comments or questions? All right, Jennifer, I think we had, a guaranteed issue. Commissioner, I'm sorry.
Mr. Chairman, members of the committee, for the record, John Gottfried, Insurance Commissioner. Going back a little on the history of how we got here today. You know, there was an amendment that was offered on to Senate Bill 2010, which is the insurance department budget. It would have been great to have been made aware and been able to have the discussion prior to that amendment being proposed, because I think we could have offered some help and offered some insight into how to accomplish what exactly that legislator was attempting to do. And so again, I'm interested in making sure we're all on the same page and filling some of the gaps here. We provided this language that you have in front of you, which would essentially accomplish creating the guarantee issue for the individual market. So if the ACA goes away, this would have sprung into effect. everything would have remained essentially the same for guarantee issued and guarantee coverage. There would have been special enrollment periods. There would have been all the things that we're traditionally aware of or used to with that individual market as it stands now. This was provided to leadership, both majority and minority, on both sides of the aisle. It was provided to the conference committee members as well. And ultimately, the decision, which I think was prudent, was to come to this study resolution, which is before you now. But I wanted to give you that as a way of a starting point for this study. It's not perfect. It was drafted in record speed, I'd say, given the end of the session. But that option was on the table during the legislative session. The ultimate decision was to come to a study, which I would agree is prudent because we've got an opportunity now to make this the bill that works and make it a bill that we can not run into any unintended consequences before we do that. But offer that to the committee. We're here to help. We're here to assist in this process as well. So I haven't heard anything I've disagreed with today on this discussion anyway. But just want to make that aware, make sure we're all on the same page where we're at.
Any questions for the commissioner? Senator Madden?
Thank you, Mr. Chairman. I'm just wondering if it might be appropriate that we actually ask the Legislative Council to work with the commissioner in bringing this back into a format that we would use in this committee to consider. It's one of those things.
Motion.
Yeah.
Is there a second?
Second.
We have a motion and a second for the discussion. The motion is to have Jennifer work with the insurance department and without a time frame. We don't have to do this by the next meeting, but within a reasonable time frame to develop a bill draft to address this issue and bring it to the committee. All right. Can we do it? We'll take a voice vote on that. All those in favor of the motion indicate by saying aye.
Aye.
Opposed, nay. All right. The motion is approved, and I certainly concur. This is one we don't have to wait. Just get some. All right. Any other discussion? Seeing none, we'll move to, I know one of Senator Rohr's favorite subjects, health facility construction and renovation study. Jennifer.
All right, so this should be your one remaining document. There was a bill, Senate Bill 2317, that is attached here. It's got two provisions. It's got one relating to health facility construction and renovation, the timeline and innovation waivers. That's in section 1 of the bill. And section 2 of the bill has to do with basic care licensure waivers. Go through the memo, there's some neat history on how these evolved and what the bill, what the bill does. And what came out of that is sections 3 and 4. Section 3 is our legislative management study here, which directs us to study the State Department of Health licensing process for health facility construction and renovation projects, including consideration of the appropriate role of the State Department of Health. And then section 4, which is also assigned to this committee, is the State Department of Health shall report to the legislative management on the implementation of sections 1 and 2. So they go hand in hand. We've got both pieces of that. And if there's anything that's in the background memo that you want me to highlight or touch on, I'm happy to. Otherwise, we did send this out to fans, so you probably had an opportunity to look over it.
Senator, Representative Anderson.
Thanks, Chairman Kaiser. I would just like to, if you're going to study the hospitals, I think you can put them in 3 different categories, like you have Fargo and Bismarck. You have towns like Dickinson, which is growing, and then you have the other rural care facilities that are outdated. They're 50 years old, and Senator Lee is right. Some of them only have 1 to 4 acute patients a day. It's pretty tough to run a hospital on that. I'm familiar with the Rugby Hospital because I'm on the board there, and the facility's 50 to 60 years old. It's outdated. Most of our revenue comes from outpatient, and we keep our long-term care up on the 2nd floor, which is a hazard. If there's ever a fire, I don't think there'd be any way we'd get all of those residents out of the hospital. So These larger hospitals in these critical access areas are so efficient that there's no way you can make money. Yet how do you get money to replace the facility is a big question to me. So it's just my comment.
Further comments? Question? Well, it's certainly an important area that the committee will undertake. All of these studies that have been assigned to the committee, we will commit to and do whatever we can to bring them forward. So, any other questions or committee discussions directed to anyone in the audience wish to comment? Seeing none, we're going to have a little bit of a discussion about potential next meeting dates. And that is September 11th. Could you check your schedule? I know that's quick. I've learned as a chairman of interim committees that you think you have a lot of time, you do not. And this committee has a lot to address, and we are going to try and schedule on a fairly regular basis. And I do understand people travel and have other commitments. Our vice chairperson, is very important to us, and she has a really tough schedule. She sent me a very nice email saying, "Why did you change the date?" I changed my entire schedule about the first day. But it was nice. So we will try and work with everyone's schedule. But Tuesday is going to be an important day.
I just hoped I read it wrong.
But we'll do whatever we can. What's September 11th?
It's a Wednesday.
It's a Wednesday, so you can change your
It works
schedule.
perfectly on my calendar.
All right. But how about Senator Lee?
I am thrilled to plan ahead, in fact, even 2 meetings ahead tentatively, so that we can put them in there and we can make sure other stuff that come along. So thank you for.
And we will get the others. And because this committee deals with health, it is, and I will argue for this, and I will win this one. We will be going to the School of Medicine soon. I don't know whether it's the next meeting or the one after that, preferably before the snow and ice is on the ground. But I will forewarn you all that the president dean of the School of Medicine pulled a fast one on this committee last interim when we went there. They provided lunch. Little did we know that the speakers at the lunch would be our entire committee, and the students and faculty were free to ask any question they may have. And it was really a lot of fun. And if you think those students are afraid to ask questions, you're mistaken. So be prepared, because I would assume he would like to do something like that as well. But we will check on availability of dates, and it might well be this next one, but we have to have legislative management approval to do it. So I'll get on that and see what we can. Senator Madden?
Mr. Chairman, just a reminder that the next day, the Human Service Committee meets, and there might be a number of people on that committee.
And that's here?
Yes.
Yeah.
Right.
Okay.
Unless they want to meet in Grand Forks too.
Well,
So many other things going on.
okay. Well, we will then leave that one here. That's important. We have just a minute. I have to share with you a little story about Senator Hogan. She and I were on a panel at the College of Medicine last year. I don't know what day it was, but Kathy, my wife, and I were driving up, and we stopped. Unfortunately, Lori Robinson's son had passed away, and they were having the evening before the funeral, and we decided to stop in. And Kathy Hogan was in the parking lot talking to someone when we drove by. We said, "Hey, Kath, how are you?" And just coincidentally, my Kath said to Kathy Hogan, "Well, we'll see you in Grand Forks tomorrow." And she said, "No, I'm going to Bismarck to a meeting." And we said, "Senator Hogan, you're on the panel tomorrow." And she said, "That's tomorrow?" But we made it and you carried the day. So, way to go. All right. We'll entertain a motion to adjourn. Oh,
Mr. Chairman, at our first meeting, are we supposed to have a motion to adopt study plans as?
We don't do motion.
Okay.
All right. I heard a motion to adjourn. The motion carries. Thank you, everybody. I apologize. I'll be right down.
No, that's fine.
I'll be right down.
Half day?